list of who has shown up, but I'd like to go ahead and looks like Rose is recording. Good morning. Welcome to the first Peb board meeting of 2022, our January meeting. And I'd like to welcome you all. And we do have a new member that is here this morning that I'd like to welcome before we get started. Dawn, and I'm going to need help with its Mountner. Sorry, Dawn, I don't know. Did I do it? Oh, good, good. Dawn, if you could introduce yourself to the group, and that would be wonderful. And welcome to the Peb board.
Good morning. Can you hear me?
Yes.
Perfect. Thank you. Good morning, everybody. My name is Dawn Mountner. She, her, a yes, white woman, long brown hair. I serve as the Medicaid medical director as well as senior health advisor for the COVID response and recovery unit. And I'm delighted to be here. Thank you very much for the invitation. My path has brought me a long and winding way from community health and the Peace Corps to practicing community-based primary care and interviewing those most frequently hospitalized in Camden and Philadelphia with Dr. Jeff Brenner and the Camden Coalition, up through the Pacific Northwest, which I call home, and academia to join the Oregon Health Authority now a couple of years ago, which hasn't been as standard an orientation as I understand it might have been. So we'll make sure that you have a little bio in your boxes, and I'd be happy to field any questions about my background. But I grew up on a ranch, and I speak Spanish, and I'm happy to provide primary care when I'm able at Virginia Garcia these days. And I am delighted to be here. Thank you for the invitation to participate.
Welcome. I love your attitude. We just welcome your smile and your attitude. Thank you for joining our board and wanting to be a part of our board. So I didn't introduce myself. Kimberly Hendricks, the chair of the Peb board, and we'll go ahead and get started. And the first agenda item up is the roll call. Oh, it is January, isn't it? So Kate Nass, are you here? Kim Harmon?
Yes, good morning.
Good morning. Dawn, yes. Sean Parkman?
I am here.
Good morning. Mark, so Mark's on here, so we don't have a replacement at this time, correct?
We should have 2 new board members by next month after Senate confirmation.
Okay, so then I call Mark and just say that, and he doesn't answer, correct? So he's on the, okay. Mark Perlman. Saban Martin.
I'm here.
Good morning. Jeremy Vandehey.
Good morning, I'm here.
Good morning. Kate Nass, were you able to join us?
Kate will actually not be with us today.
Okay. Okay, so Kate and Mark will not be with us today. Well, welcome. And our next agenda item is the minutes from the December 21st of 2021. I hope you've all had a chance to review those, and I will entertain a motion.
This is Siobhan Martin, and I will make a motion that we adopt the meeting minutes as written. I know Rose sent out a revised version this morning.
Thank you. So we have a motion to adopt as written the revised version that was sent out by Rose on today. And do I have a second?
This is Jeremy, I'll second.
Thank you, Jeremy. Any questions, comments about the minutes? All in favor of adopting the minutes?
Aye.
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 Kim?
Aye.
Aye.
Okay. Looks like everyone approved of the minutes, and no disdain or no nay. Everybody was aye on the approving the minutes. Okay, gotcha. All right. So, COVID updates. Now, I believe, so if I do the math, these are quick COVID updates. These are fast speed COVID updates before we get on to our annual renewal primer. So first up is Kaiser and Dr. Keith Bachman.
Okay, I will set a timer here and keep it to exactly 5 minutes. So, as everybody knows, Omicron is here and rapidly changing the face of our worlds and healthcare in particular. It's highly infectious, as you know, with a lower incubation rate of 3 to 4 days rather than 5 days and more. People are most contagious for a couple days prior and a couple days after symptom onset. So this is allowed for recommendations for just 5 days of isolation. However, it's super infectious, which is having impacts, as you all know, on employees in healthcare settings and in other face-to-face settings. So this is why this is really having the impact that is having. We know that vaccines are effective at preventing serious disease, and we know that the booster is critical at both helping to prevent disease and actually helping people from getting it. So all efforts really need to be continued made at booster vaccination. A word about testing. So there's the PCR testing and there's the antigen testing. There was an executive order from the federal government reimbursing for home tests as of January 15th at Kaiser Permanente. I guess all health insurances, if someone can get the tests, which are in short supply, they can submit for reimbursement. That's not an insubstantial cost. So for a family with 8 tests per member per month, with the current sort of retail cost being around $12 a test, that is a potential significant healthcare expense. Well worth doing because it's still cheaper than PCR testing, but it's going to be more available. The issues with the antigen tests is they are great when people are having symptoms. They're great sort of for low risk environments. The test becomes more and more accurate with the higher prevalence of COVID. So we're getting to an environment where these tests are actually getting to be very useful. They can detect some asymptomatic infection, and the technology just to make the connection. The technology is the same as being used for a home pregnancy test. So it's a fairly well-known technology being adapted to detect the antigen of COVID. So the PCR tests still have a role. The nice thing about the antigen test is it comes back within 15 minutes, right? But for the PCR tests, that still takes a day to 2 days to come back. Unfortunately, at Kaiser Permanente, we had a problem with one of our devices, so we are now currently at 3 days to get a test result. We've been sending some tests when we hit our maximum of 3,000 a day down to California. They have a larger testing facility. We expect it to go back down up to 3,000 tests a day when the machine comes back on in a few days. We are having to limit it. We're recommending that only people who are high risk and symptomatic get the PCR test, or people who need to have medical procedures, or people who need to go to an environment like being admitted to a nursing home. In terms of vaccinations, currently 91% of Peb subscribers have been completed or started a vaccination series. That's for Kaiser members or Peb subscribers. 54% of Peb subscribers have been boosted. If you including dependents, that's down to 80%. Including some more kids in that, some who are not yet able to be vaccinated, and some who are still sort of beginning their series. Very high levels of case positivity among Peb employees currently, as we're seeing with our book of business. 31% of all tests are being done are positive now. This is way higher than it's been at any other time during the pandemic. Some of that is probably shortage of test supplies, and some people affecting that, and some is just how contagious and how prevalent Omicron is. Hospital census currently for Kaiser Permanente is 117 cases. 2 weeks ago, I was updating these numbers for the OEB meeting, and it was 52. So we've had over doubling of hospital cases over the last 2 weeks. 8 of those Kaiser cases are being treated as inpatient at home through our KP at Home program, which is a home service that provides hospital level monitoring with 24-hour-a-day nursing care by video, physician care by video, and any other technology we need at the bedside to manage it. With COVID, it's relatively straightforward with simple to use IV medications, high flow oxygen, and we know enough about it that we can identify who is safe to be managed in our hospital at home program. Currently, the standard Regeneron monoclonal antibodies, we're not getting those from the state. They're not that effective for Omicron, so we're not providing that. The other antivirals are in very, very short supply. Members at the highest risk, such as after organ transplantation, after bone marrow transplantation, can get them through Kaiser Permanente as supply from the state allows. And so we're just really waiting for the supply of the oral anti-COVID medications, as well as the Evusheld, which is COVID preventive for people at high risk, really for the supplies to become available so we can deploy them. We will be deploying them across our book of business, identifying the risk factors for severe disease, which is primarily biologically based, but then socially based, and determine who would be most appropriate for those techniques. So that said, just the bottom line, this is no news to anybody. Stay home, get tested if you're at high risk. You can assume, given the high prevalence of disease, if you have fever, headache, cough, loss of taste and smell, it's likely COVID. You can treat yourself for COVID with that. Let us know or let your doctor know, but it's really staying at home for 5 days. Then if you need to go back to work, very carefully mask. Changed work environments. We've changed our protocols in our cafeterias and break rooms, really to have one person at a table, minimize the unmasked time. We're careful to use appropriate PPE at all times, and we understand the increased, because of the infectiveness of this and because of the high prevalence in the community, the shortage of healthcare workers is a challenge, and that's going to really what we're facing. 2 years ago or a year and a half ago, it was really about the PPE, and that was really the constraint. Was it safe? How do we manage that? And now the problem is situations where you'll lose several people in a nursing unit due to actual COVID, not just exposure. So, so that's the word from Omicron at Kaiser Permanente. I will turn it over back to Kim and to Yale.
Thank you so much. Thank you. And next up is going to be Moda, Dr. Robinson. Oh.
Okay. No, this is Dr. Popowich, but thank you. And thanks, Dr. Bachman. It's always humbling following you in these presentations because you present so much fantastic data. So I will do my best not to be too repetitive and give you the Moda perspective on what's going on. So as of this week, the CDC has reported 209 million people have received a full series of the COVID-19 vaccine, with 79.7 million having received a booster. In Oregon, 67.2% of the total population is now fully vaccinated, with 43.9% also having received a booster. Nationally, we're looking at close to 67 million cases and 848,000 deaths. As Dr. Bachman also spoke extensively about, with what started out as a whimper just a month ago or so, it seems, maybe a bit longer, the Omicron variant has now built to a tremendous roar in Oregon. In this past week alone, the U.S. is reporting the highest 7-day average of new COVID cases than at any point in the pandemic. There is optimism among scientists that this Omicron surge will be swift, but it does not mean that COVID by any means is going to be over. In lab studies to date, Omicron has been shown to be far less aggressive to the lungs than prior variants, which could explain the lack of a surge in deaths and hospitalizations. One of the main reasons hospitals are struggling right now more than ever is the shortage of skilled workers and losing members in the workforce. New oral medications from Pfizer, the Paxlovid, and Merck's Lagevrio may offer some benefit to newly diagnosed patients if given within 5 days of symptoms. The data is scant, and these are by no means going to be the silver bullets many had hoped for and initial reports had praised. At the end of the day, guidance is the same for everyone. Get vaccinated and boosted, especially with boosters available for most age groups now, including Pfizer's vaccine for 12 to 15-year-olds, as well as 5 to 11-year-olds who are immunocompromised. I'll next dive into the most recent Peb data. So overall, 79.3%, up from 71% of all Peb subscribers have had their full vaccinations, and 34.5% have had their booster. Encouraging is that in the 12 to 18-year-old age group, 54.9% are vaccinated. And we will continue to track these younger age groups as the data becomes more available. For a brief regional breakdown, the Portland metro area, we're looking at 86.7 fully vaccinated with 46.5% boosted. In Eugene, 82.8%. Salem, 80.2%. The Oregon coast, 79.1%. which is up quite a bit from the last time we reported. That was at 68%. Central Oregon is up to 69.5%. Eastern Oregon is up to 73.5%. Also extremely encouraging, seeing as the last data was 54.8%. And Southern Oregon as well, 73.5%. So overall, 1,057 Peb members have had a COVID diagnosis. That's up from 641. And overall, 42 members have been hospitalized with a COVID diagnosis, up from 33. What is stable, however, is we have only had 3 Peb member fatalities. So as Dr. Bachman also mentioned, these latest federal guidelines dropped right in the middle of last week, and we responded as quickly as we possibly could. And in full compliance, we will reimburse COVID-19 at home test purchased by members starting January 15th and after. Members should show their Moda Health ID cards at any in-network pharmacy counter when purchasing. Reimbursement options are available for members when they are purchased at one of our in-network pharmacies or at an authorized retailer non-pharmacy location, in person or in line. There are reimbursement forms available on our website for each type of reimbursement. It is important to note that there are 2 different reimbursement forms. One is used when seeking reimbursement for tests purchased at a pharmacy or online pharmacy, and a different form is used when seeking reimbursement not at a pharmacy. Following federal regulations, we will reimburse up to $12 per test for tests purchased on January 15th or later. We will reimburse up to 8 tests per 30 days for each person on a Moda Health plan, no matter if the tests are bought all at once or at separate times during the 30-day period. Moda will cover up to 8 tests if they are bought individually or in a pack that includes multiple tests. Please note that shipping costs will not apply to the reimbursement. There are clear instructions on our website on how to find an in-network pharmacy, as well as more detailed instructions on this topic and an FAQ as well at www.modahealth.com/Peb/COVID. So the messaging to all members, as Dr. Bachman said so wisely, as we are continuing to encourage vaccination, and vaccination still will be the greatest protection you can have from Omicron or any other variants that may come up in the future. And that's all I have from the Moda perspective.
Thank you so much. All right, Providence, and I guess I won't guess on who's presenting for Providence. I'll just see who pops on here. It's either going to be Helen or Jessica.
Hello, this is Jessica Nicolcha from Providence. Can you hear
Good.
me?
We can.
Okay, perfect. I will go ahead and I will go fairly quickly just because a lot of the information I will give will echo a lot of what Kaiser and Moda has said as well. So starting out with just some of the numbers, as of yesterday, 74.9% of Peb members are partially or fully vaccinated, and that's age 5 and above. And that is an increase since September of 73.6%. So it's an increase, albeit a slow increase. But that is falling in line with approximately 72.4% of Oregonians have received the first dose and 65.6% are fully vaccinated. Within the US population, we have around 62.9% fully vaccinated. Ages 41 and older are all above that 85% of COVID vaccination, with again, a little bit less vaccination rates in those younger populations. I won't take too much time going into that, but Peb member booster rate is 36.6% as of yesterday, and this is falling in line with what we're seeing not only in Oregon, but also nationally, with 30.5% of Oregonians having received their booster doses and 38.1% of individuals in the United States having received booster doses as well. As other individuals have stated, we are expecting a surge of COVID-19 cases in the upcoming days to week, as stated by the CDC, based on the Omicron variant. And so we are continuing to recommend vaccinations and boosters if eligible to certain individuals. Booster shots, there are quite a few new updates to booster doses. So everyone ages 12 and older who are eligible for booster shots. And it was recently updated that individuals can receive a booster shot at least 5 months after completing their primary vaccination series of a Pfizer or Moderna vaccine, and then at least 2 months after receiving Johnson & Johnson. Really emphasizing those booster doses. Individuals have already mentioned the COVID-19 antiviral medications taken by mouth, and I do just want to emphasize that at the moment, these two medications, Paxlovid and Molnupiravir, are distributed by the federal government and state health departments, and so access to these agents currently are limited. And this is the same pattern that we did see with monoclonal antibody therapy in the past too as well. With monoclonal antibody therapy, based on the genetic makeup of Omicron, some treatments are not quite as effective, and so we're seeing a decrease in the use of these agents in general. Based on the recent COVID-19 U.S. Department of Health and Human Services, HHS announcement that requires insurers and health plans to cover FDA-approved over-the-counter tests. We at Providence are covering at-home COVID-19 tests and reimbursing, and on our website, we do have a reimbursement form that members can fill out, and these are for COVID-19 over-the-counter tests obtained at local pharmacies, in and out of network, local retailers, or online retailers as well. And so individuals, if they have purchased these in the past, can fill out that reimbursement form. And members may attach multiple receipts as well to a single reimbursement form as well. We are continuing updating our member COVID-19 website with up-to-date information. We are continuing to post blog posts such as how to talk with family and friends about getting vaccinated with COVID-19. Providence is continuing to have local COVID-19 clinics through PMG. We have drive-through clinics for vaccinations and testings. We also have community clinics as well. And then we do have a COVID-19 testing location, and are also encouraging individuals to use additional COVID-19 testing location finders, just because the access to it at the moment is a little difficult currently, but we are trying to provide members with the most up-to-date information that we possibly can on our COVID-19 website. Thank you so much.
Thank you, Jessica. Okay, so there's a little bit of a change in the agenda. Oh, did you have a question, Sean? Sorry.
Yeah, quick question. This is for any one of the carriers. Does anyone have experience with in their book of business with offering incentives at this point for boosters specifically? Yeah, that's the question.
We're going to be doing a few community-based pilots to see if that's effective, and can report back on that. That's at the end, towards the end of the month.
Okay, thank you.
And hi, this is Katie from Moda Health. I just wanted to comment that for our Medicaid population, the Eastern Oregon CCO, we did have an incentive for COVID vaccinations and boosters. And if the next question is how did that impact results, I'd say it's a great one, and we'd have to go back and need to ask the right subject matter expert to get that number.
Okay, thank you. I would appreciate that at some point.
No problem.
And Sean, this is Ali. You know, that's something that we could pursue with board leadership and discuss further as well.
Okay, thank you.
Any other questions for the carriers about COVID updates? Okay, so we have a little bit of a change. We have an addition. Cindy Bowman is going to give us an update. We have a tendency to beg her forgiveness and take her off agendas. So she is going to give us an update, and we appreciate that you're here. Welcome.
Thank you, Kimberly. Can you hear me? Okay, good. All right, I'm going to try to share my screen. Let's see if I can. Okay, it's being shared. Okay, so for those of you who don't know, I am Cindy Bowman. I'm the Director of Operations. I think I know everyone probably except for Dawn. I am going to move this over so I can actually read it. And now I've messed up sharing my screen, I bet. Are you seeing my family right now? I'll move it back. Okay. So I just wanted to come and talk to you. We actually need board action today. We have, during the course of COVID, and this was clear back in 2020, to tell you the truth, we were trying to keep up with a lot of actions that the federal government was taking. And some of those relate to our flexible spending accounts, both the healthcare and the dependent care. So we did, in this instance, talk to board leadership, but it occurred to us that we never brought it to the board. So we are bringing it to the board and need some action today. So this relates to the grace period associated with these plans. Normally, a grace period runs for the first 2.5 months after the plan year is ended. So usually March 15th is the end of the grace period for our plans. With COVID, we found with healthcare, people were obviously not going in and seeking treatment. You make your plan selections in October the prior year, thinking you're going to go see the doctor or you're going to take your kids to daycare. And well, obviously that didn't happen in 2020. So balances were accruing, and at one time, I think it was in May, the IRS said, employers, you can allow your members to make changes. So we agreed to do that, and in May 2020, we allowed members to stop their contributions if they wanted. Normally, that it extends through the full calendar year. So we thought that would give members, because of the grace period extending through March, even though they weren't using it for that time period, that they would have an opportunity to use the balance that they had in their plans by the next grace period. So in December 2020, the IRS approved employers to roll over any unused balances that were in there. So from January to May of 2020. We thought, oh, surely members will be able to do that. And we were informed by members that that was not true, and they still weren't seeking services, and they still had unused balances. So in April of 2021, we worked with ASI Flex, who, although we we couldn't offer a rollover because you can offer either a rollover or a grace period. We could extend the grace period, though, through the end of 2021, so December 31st. So in effect, what this means is any expenses that a member had in 2021, they could actually apply that 2020 balance, unused balance, to that. So we did talk to Sean and Kimberly at the time, and everybody agreed that that would be a positive thing for our members. But again, we didn't bring that to the board for a formal vote. So that's what we want to do now. Claudia and Brian have been working on the contract amendment that enables us to extend the grace period through December 31st, 2021. And what that means is members had until then to use services in that year, but they still have till March 31st to actually submit those claims. So I just wanted to clarify there is still that submission period that extends to the end of March. So what we're looking for is the board to formally approve extending the 2020 healthcare and dependent care FSA grace period through December 31st of 2021. So all that was a mouthful. If you have questions, I'm happy to answer them. I'm going to I'm going to unshare my screen because I can't see you there we go. Okay. So did you have any questions about that? I know it was kind of convoluted.
I don't have questions. I was going to make a motion unless there are questions. Okay, I'm going to make a motion that we extend the flexible spending account through December from 2020 for people to be reimbursed through December 31st of 2021 for both the dependent care and the healthcare flexible spending accounts per what Cindy just shared and board leadership action on it.
This is Jeremy. I'll second.
Thank you. Any questions? Comments? Okay, let's go ahead and vote. Kim Harmon?
Yes.
Thank you. Dawn?
Yes.
Thank you. Sean?
Yes.
Thank you. Saban made the first and Jeremy the second. Looks like this motion passed. Was there any opposed? Okay, well, thank you, Cindy, and we're glad that we were able to get you in and take care of board action. We appreciate you. We really do. All right.
Thanks so much.
Now, thank you. Now we are on to the Peb annual renewal primer, and Mercer is going to kick us off. So good morning, Mercer.
Hello, can everybody hear me?
Yes.
Struggling to get off mute there. Thank you, Kim. And hello, everyone. Really glad to be with you here today. My name is Andrew Hoffheimer. I think probably most folks on the call were introduced to me last Tuesday during the Mercer Value Prop meeting. But for anyone who couldn't attend, I have stepped into the Mercer lead consultant role, which was previously filled by Nick Albert. And so I'm looking forward to getting to know everyone and working with you all as we start to plan for 2023. And so today we have the Renewal Primer presentation. So we're going to go through a quick recap on successes for the 2022 plan year. We'll start to talk about 2023 planning. We'll provide a market update, and we'll do a quick wrap on next steps and timeline. Like Dr. Bachman, I am setting my timer, and so we're going to do our best to manage to the 30 minutes we've been allotted. But that said, any questions that come up, please don't hesitate to stop us, and we can take those as we're going through. And so I have my colleague Mitch Nigro on with me, and so for this first section, I am going to hand it off to Mitch.
Good morning, everybody. I think most of you have seen my face last year. My name's Mitch. I'm a senior associate here at Mercer. So this first section, we're gonna kind of do a recap on what we did last year, and kind of help reset for the 2023 renewals. So if we can go to the next slide. This first slide, I think we've all seen this. This is the guiding principles that we've developed about 2 or 3 years ago that kind of start with the triple aim and trickle all the way down to the 3 success measures. So I won't go through all of this, but one of the key things that I wanted to highlight here was health equity. And so that's been a key area of focus within the last couple of years. And it's kind of something that we keep more prominent when thinking about renewal decisions for the next year. If we go to the next slide. So more on key health equity. So this key health equity strategic pillars were developed 2 years ago, I believe now, at the November 2020 board retreat. And so we just wanted to include this here for additional context as we look for 2023 renewal decisions and items that come up. And so if we go to the next slide, so this slide is kind of a recap of what we did last year for 2022. And so we kind of took we bucketed these items into 3 areas: better quality, better value, and better member experience, that kind of relate back to the guiding principles. So if we look at better quality, so this kind of talks about how we reviewed the performance guarantees. So as a recap, performance guarantees are just a set of metrics that carriers are willing to put at risk for items like clinical quality, administrative and operational, or financial guarantees. And so looking at the 2021 ones, between Kaiser, Moda, and Providence, they were all over the place. They were different metrics, different percent of fees at risk. So Mercer and OHA staff came together and set some meaningful metrics based off evidence-based metrics to kind of align everybody at 15%. And so the outcome of this is the carriers agreed to put 15% of their fees at risk for clinical quality, administrative and operational, and financial guarantees. Kind of going down to the next one, better value. So these are some additional cost savings that we had. I remember last year, we talked about administrative fees a lot. So we looked at these against Mercer's book of business, and we found that the administrative fees were, significantly higher than what we're seeing in the market today. Out of this, we achieved $1 million worth of savings across Moda, Providence. And additionally, that bottom bullet, there were some additional savings from negotiating the Kaiser renewal down. So almost $6 million worth of savings there. So that was great. The last one, better member experience. So again, tying to health equity, tying to the guiding principles and reducing disparities. We did a full review of the gender affirmation coverage last year and helped align better WPATH standards. Additionally, we added the fertility benefit, which is great. It's a $35,000 benefit to your members to use on ART, or artificial reproductive technologies. And so then if we go to the next slide, here we go. So this one is kind of a recap of some of the work we're doing in 2022 that's still ongoing and kind of what we're looking at in 2023. So kind of over there on the left in that lighter blue, project's still in progress. So there's still some things that we're working through. The performance guarantees, we're ensuring that those are still going to be met for 2020 or for 2024 or 2023 and ongoing. Sorry, I can't tell years this morning. And then there's additional projects going on access and quality of care, as well as we're always reviewing programs to better help the member experience. But that middle column, or the lighter blue or darker blue, the 2023 planning, is what I wanted to talk about. I'm not going to read this to you, but so these are kind of just some items that we've put into the round 1 renewal letters that we've had based on feedback and other items that came out of 2022. So some of the highlights, we're going to continue the DEI vendor capabilities, such as provider directories and ensuring health equity across all members. Review the digital landscape, especially when it comes to diabetes prevention programs and things like that. Continued ongoing COVID-19 support. Hospital caps have been a big one for a while now, and so we just want to get a better understanding of that. Some review of medically necessary procedures, and then ensuring value-based payments and meaningful solutions while staying under that 3.4% cap. And then the last one's kind of cool. It's just some alternative deliveries of care. So kind of, reviewing other non-traditional ways members can seek care, such as traditional healthcare workers like doulas and items like that. And then kind of looking at the darkest blue, potential actions for now and beyond. So this again ties to the long-term care strategy or long-term strategy. Obviously, health equity is top of our list, as well as reducing waste in the delivery healthcare system. And a medical RFP. I know we've talked about that before. And so possibly, tying that into our long-term strategy and so forth. So if we go to the next slide, I believe that is the end of this section. Yep. So was there any questions on that before Andrew dives into the market update? Great.
All righty, thank you, Mitch. For this next section, we're going to spend probably the bulk of the 30 minutes really in this section. Because we're so early on in the renewal process, it sort of gives us the opportunity to do this general market update. So what are other plan sponsors focused on? What are emerging solutions? What are we seeing from a vendor landscape perspective? All that sort of good stuff that we like to sort of keep our eyes on. And so for this first slide, what this is looking at is the average healthcare costs nationally, which is that blue line, compared to workers' earnings, which is the green line, and overall inflation, which is the pink line. On the right, that dotted line is the 3.4% total cost cap. And then we've introduced the purple line starting in 2015, which is Peb specific. And so looking at the left side of this, this exhibit, you can see that for a long time, healthcare cost trends were far outpacing worker earnings. And so what that meant was that every year healthcare was a little bit less affordable. And so fortunately, that delta has compressed a little bit in the last 10 years or so, although you'll still see that typically in most years, healthcare costs are increasing at a faster rate than workers' earnings, again, putting a squeeze on workers in terms of having affordable healthcare. And so Peb has done a great job managing costs. You can see that Peb costs have been at or below 3.4% since 2015. You might notice a little blip in 2020 where it's above that dotted line. That's just due to the timing for the PEPM calculation for the data point that we use in this exhibit. But the really positive message here is that because costs have been managed so effectively, that squeeze that gets put on workers when there's that disparity between healthcare costs and worker earnings has been pretty heavily mitigated when it comes to the Peb specific population. All righty, next slide, please, Rose. And so when we're talking about costs and health plan value and sustainability, there's a couple of things that that we need to talk about. And so along this top row here, we've got a few data points based on things that are happening in the market today. So based on Mercer research, we think there's about $2,000 per employee per year of poor quality healthcare costs. And again, that's not Peb specific. That's a national data point. And so that includes things like waste, unnecessary services, perhaps related to fee-for-service arrangements. And as we walk along that to the right in that top row, the next data point we've included is around value-based care for Peb specifically. And so in the most recent reporting period, 45% of Peb payments were actually tied to payment arrangements of 2A or better. What that means, 2A is, so the Learning and Action Network has classified different payment models along the value-based care continuum. 2A is fee-for-service, but with ties back to quality and value. And so this is a great result to see 45%. The converse is that there's still 55% of payments that are tied to just a pure fee-for-service payment arrangement. And so there's still opportunity there as well. On the far right at the top, 80% of members, based on the surveys Mercer have done, have embraced telemedicine and will continue to do so post-pandemic. And so this is quite a big change that we've seen since the pandemic started in 2020. And so we're going to spend some time in a few slides talking about that in a little bit more detail. So in this bottom row, what we've done is to pull out some data points around what we think is a good sort of peer group, benchmark group around state governments with at least 500 employees, just to see sort of what are they focused on and what actions are they taking as they prep for 2023. And so almost 20% within this peer group are considering offering advocacy. This is a great way to support members to help them navigate the healthcare system, provide clinical support, help refer to all of the benefit programs that are offered by the plan sponsor. And so this is something that we're seeing a lot of attention across the board with all sorts of different clients right now. 33% within this peer group have implemented high performance networks, and so things like narrow networks or ACOs. And then 57% within this peer group of state governments are expanding access to virtual care. And so that could be traditional telemedicine, like MD Live, Doctors on Demand, but it could also mean virtual behavioral health solutions, virtual point solutions, and so there's more that falls into that category than just your traditional telemed. Next slide, please, Rose. And so when we talk about sustainability and high value care, there's a couple of different ways to look at this. And so what we've done here is to include 5 high value care strategies along the top, and then some digital front doors along the bottom. And so in terms of high value care strategies, advanced primary care is one. This is sort of like an ACO, but without the risk sharing. It's sort of a multidisciplinary team of providers who are providing patient-centered care. Virtual care, we've talked about a little bit, and we'll talk about that some more in a few slides. High performance networks, again, these are your ACOs, your narrow networks, et cetera. Centers of excellence is another high value care strategy. And I know through IWG, the board is looking at a musculoskeletal center of excellence, which is great. That's definitely one of the most common types of COEs. And COEs can be a great way to support members for lots of reasons. These are high quality providers, and typically their out-of-pocket costs are going to be lower. There are some challenges around steering members to COEs, and so ways to combat that are to introduce incentives, introduce an advocacy vendor is another way to create awareness of the COEs and steer folks to them. Reference-based pricing on the far right is not something that we see a lot these days. Maybe 2 to 5% of employer plan sponsors have these in place today. With reference-based pricing, basically the plan sponsor is setting a ceiling on how much they're willing to pay for a given procedure. And so it can lead to some member noise and dissatisfaction. It can lead to balanced billing. It's typically used for more commodity type procedures because quality often isn't taken into account. And so it's a cost savings strategy probably more than anything. Yes.
Yeah, so I just wanted to chime in here. I know we're going to talk more about COEs later in the agenda, since we have a report from the Innovations Work Group that covers that. But just as we look to 2023 and looking at the Centers of Excellence models, I know that quality is the biggest thing around those, but when offering incentives, we also have to make sure we're getting a good price. And just wanting, if you can comment on that, or that's something we can look further into, because Obviously, we want really good outcomes for folks when they go to centers of excellence, and we want those prices to be reasonable. And when you talk about reference-based pricing and then that sacrifices quality, we need good quality and reasonable prices. So just want to highlight that.
Yeah, that's a great point and a great question. And so one of the trade-offs when you're partnering with these centers of excellence is what you're providing them is volume. And so what they're providing back to you is typically a lower cost. And so it's sort of a two-pronged strategy where quality is absolutely important. If those aren't high value providers, they're typically not invited to participate in the COE. But the trade-off that you're making with whoever is managing that COE, whether it's through one of your carrier partners, or if it's a carve-out COE, or if it's a custom COE with a hospital network, you're providing volume to them, and they're providing you with a better cost. And so that's going to help Peb manage to the 3.4%. It's also going to help members in terms of their out-of-pocket costs.
Thanks. So it'll just be helpful as we continue to look at COEs, how we're going to get those much better prices for the volume.
Yeah, absolutely. Okay, and so a digital front door is another area that's getting a lot of attention with emerging virtual care, and plan sponsors thinking about, well, how do we get folks engaged with all these awesome solutions that we're putting in front of them, and high value care models, et cetera. And so there's a couple of ways to do that. AI triage is one. This is one where, as a member, I can input my symptoms and I'll get some recommendations based on different care options. And so it'll help steer me to sort of the most appropriate site of care. Digital navigation is another one. This is an area where, as a digital front door, I can use it on my phone, and it's going to help me find providers or review costs. I can post questions about my bill. I can get referrals, et cetera. And then advocacy on the far right is a service where I, as a member, I can call and speak with a health advocate, and they're going to help me navigate whatever my issue is related to healthcare. They can also provide clinical support, expert medical opinion. They can refer me to all of the sort of myriad offerings that Peb offers. And so this is an area that's getting a lot of attention as we think about, plan sponsors sort of wrestle with this issue of how do we get folks engaged in these solutions that we're making available to
them. So just to plant a seed here for this conversation on the digital front door, I'm wondering if there's any studies or data at this point around outcomes related to health equity. So this presumes, digital solutions presumes some level of digital access, internet access. It implies a certain familiarity and comfort with digital interventions, and I'm not afraid of having an intervention that's kind of specific for one group, but I am interested in the sort of equity implications of sort of going headlong in this direction. And I'm wondering if there's any studies about that outcome in particular. Health equity. How does digital solutions interface with health equity?
Yeah, and I can provide my response, and I would welcome others to chime in as well. There are shortcomings of some of these virtual solutions, whether you're living in an area that doesn't have reliable Wi-Fi, or maybe you don't have the right technology, maybe you don't have a smartphone. There are shortcomings around members living with disabilities. And so can they access these solutions if they're, vision impaired or hearing impaired? And so sometimes these sort of get trotted out as the end all be all, and they're really not there yet. They are improving in a lot of ways, but there are still segments of every population that are going to have access issues as it relates to these virtual solutions. And so I view them as a useful tool, but there's room for improvement when it comes to reaching some of those disadvantaged populations. Whether that's rural folks or maybe it's employees who are less digitally savvy, and so there's definitely opportunity for improvement. When it comes to specific studies, I think we could take that as a takeaway. I think there likely are some. I don't know what those results are off the top of my head, but it's a great point and discussion around, well, how do we make sure there aren't folks who are sort of falling through the cracks, because these aren't going to work for everybody.
Right. Yeah, I would appreciate that. Yeah, a future conversation, and perhaps by way of suggestion for Ollie and the agenda and Mercer in these conversations, perhaps we make a commitment as a board that when we discuss digital solutions, which I do think is a part of the future solutions for a lot of our needs, that we pair it with a conversation, maybe every time, maybe it's like they go together, of how are we going to be addressing the needs of those that will be left behind by this technology, so that it's kind of a joint conversation every time. So that's maybe a strategy for us as a board.
Yeah, Sean, I think the plan is to use the health equity tools that we put together in any new programs or policy decisions would undergo an analysis under the disparity section of the tool, and just the health equity lens tool overall. So definitely.
And Dawn has her hand up.
Thank you. Thank you for that presentation and that really good question, Sean. The issue of equity in is one that that's getting a lot of attention right now, and there's a lot of new and emerging data about it, but it's complicated. Some of it says that inequities are improved by digital technology and access to telehealth, and other studies say that they're worsened, that they're exacerbated, and you really have to get into the details. We have a huge amount of new data with the pandemic because of the expansion of telehealth, but it's probably really worth looking at that, and not specifically and only for telehealth, probably. And digital access, but using the equity frame to consider sort of all of the services that are being provided, and being sure that we're improving inequities with them and not making them worse. And I would trust that the plans are each leveraging their own thinking and tools and expertise to be examining those data and examining their own data with regard to their outcomes, and making sure that if there are inequities in how those interventions are impacting their subscribers, that they are working to address those. And so that equity question, Sean, really lit off a couple of things for me, and I appreciate that I'm brand new and learning. So thank you.
Hey, those are all great points. So if we want to jump to the next slide at this point, Rose, I think that a lot of folks have seen this one, so we don't have to spend a lot of time here, but this one sort of lends itself to the equity and member support discussion as well. This one shows, based on Mercer's research, which was conducted in September of 2021, we asked members, what experiences have you had since the pandemic has come up? And so at the point that this was taken, we were deep into the pandemic. And so 16% of respondents said, well, actually, I have had these positive experiences, which you can see listed in blue there. 33% of respondents said, well, actually, I have had primarily negative experiences. Here are the top 5. Financially worse off, I'm lonelier, I'm less healthy, I'm less fit, I've had mental health issues, and work is less satisfying. And so there's a huge need right now, which lends itself to a huge opportunity in terms of, well, how do we support folks? Folks are going through a really difficult time. And so how do we support our member base? So if you flip to the next slide, Rose, here we've got 5 sort of broad strategies that do just that try to support members based on what they're experiencing right now in the pandemic, as well as everything else, the social unrest, everything that's going on right now that is sort of creating a huge opportunity to try to support folks in ways that maybe haven't been explored in the past. And so at the top there, supporting moments that matter. This one is around sort of recognizing that there are non-traditional ways to support folks that are outside of your sort of traditional view of health insurance. And so that could be ancillary benefits like caregiver support or financial well-being. Moving along the right, the next broad strategy is providing varied and valued benefits and sort of recognizing that one size doesn't fit all from a benefits perspective. And so provide a wide variety of benefits and provide high value benefits. The next one, enabling digital access to healthcare, we've talked about a little bit already. There's a lot of pros here. It's convenient, can increase access. It can support and actually counteract some inequities around access for folks living in rural areas, for example. It can sort of exacerbate existing inequities for folks with disabilities who maybe can't access these solutions or folks who don't have a smartphone. And so definitely a nuanced area per Don's comment. It's not black and white here, but it's definitely the equity piece has to be a part of this conversation around virtual healthcare. The next one, investing in mental health. I think probably everyone on this call knows that there's just a critical need in this area. So actions to support members could be identifying gaps in the care continuum, looking at EAP, visit limits, looking at virtual behavioral health solutions. And then the last strategy is delivering benefits equitably. And so this one asks the question, are benefits being designed to meet the needs of everybody, including disadvantaged populations who have been hit more negatively during the pandemic than other the general population? And so actions could be around cultural competency and inclusiveness, or it could be around social determinants of health. How are those identified and triaged, and how are folks referred out to community-based organizations if risks have been identified? And so there's lots of strategies that the plan sponsors are focused on in this area as well to try to support members. So if we flip to the next slide, what we've done here is we've looked at Peb Demographics specifically. And so we've got the gender breakout in the middle. The ring in the middle with the various colors is the generational breakdown for Peb membership. So you can see that Gen X has the most membership, followed closely by millennials, quite a bit of baby boomers, and then smaller slice for Gen Zs who are sort of just starting out in their careers, and traditionalists who are more focused on retirement. And so these statements on the outside of the circle are not Peb specific. This is based on Mercer research into generational priorities. And so again, it's not specific to any research that's been done on Peb member priorities by generation, but it can be sort of a useful lens to look and see, well, generally speaking, what are some of these priorities for folks in just generally in their lives? And so that strategy around supporting the moments that matter sort of speaks to this. Is like what ancillary benefits can be provided to support folks? And so some of these are around family. And so maybe caregiver support lends itself to supporting those priorities. A lot of these around personal finances. And so what programs can be put in place there around financial well-being for, debt consolidation and refinancing, or preparing for retirement, or what have you. If we want to flip to the next slide, Rose, we're going to spend a little bit more time talking about behavioral healthcare specifically. Thank you. And so on the left, what we're showing here are what are the top priorities for large plan sponsors. So any plan sponsor with at least 20,000 employees. And you can see priority number one, expanding behavioral healthcare access. There are some others as well that you can read through at your leisure. But you know, again, this is probably not a big surprise. There's a critical need right now. There's sort of a dearth of providers in this area. There's access issues. There's still lingering stigma, and so there's a huge need. And so if you look on the right, we've pulled some Oregon specific stats. So 35% of adults in Oregon have symptoms of anxiety or depression, and 35% of those needs are currently being unmet. And so that's Oregon specific. That's not Peb specific necessarily. But when we look at Pebb utilization data, claims related to mental health and substance abuse are up 10% in the current reporting period. So that equates to a little more than $6 million. And so when we think about where are the Pebb members located geographically that are, you know, tapping into these types of services, most are along the I-5 corridor, probably not a big surprise there. But 17% of utilizing members live elsewhere. They live in Eastern Oregon or Southwest Oregon. And so, you know, access issues can certainly be a big factor in some of those rural areas and elsewhere, frankly. And so one potential way to combat access issues, if we go to the next slide, please, and stigma is around virtual behavioral health offerings. And so before we get into that specifically, on the left here, what we're showing is for plan sponsors with 500 or more employees nationally, you can see a big jump in telemedicine services in 2020, in year one of the pandemic. And so if you look on the right, we're now looking at Peb specific data. You can see a similar really big jump in 2020, a huge jump. And then it's maintained and actually goes up a little bit in 2021. And so these are services utilization per 1,000, and we've broken it out into mental health substance abuse in blue and non-mental health substance abuse in green. If we want to jump to the next slide. And so this is a little bit more around virtual care, including virtual behavioral health care, which again is great for access and can reduce stigma. But this calls out 5 different categories that fall under virtual care. The top one being your traditional telemedicine, which almost all plan sponsors are offering now, which is great. But you can see as you sort of move down that list, things like virtual behavioral health care, about a little more than a quarter of plan sponsors offer it today, but another 20% are considering it. And the same is true for targeted virtual health solutions, things like Livongo and Hinge, which are for diabetes and musculoskeletal, respectively. And then at the bottom, virtual care PCP, you know, has some emerging interest, and then AI triage as well is not quite there, but definitely something that could start trending up in the next few years. Okay, if we want to flip to the next slide, please, Rose. We like to refer to this one as the clamshell. This one shows your current partners and where we've sort of slotted them into these different service areas. This can be handy to see if there are any gaps that we can identify and then fill those gaps. We do have the Moda 360 there in the center of the clamshell, which, you know, as a navigator, this service can help sort of triage folks and refer them out to all the various things that they have available to them based on, you know, whatever the navigator has identified in conversation with the member. And so we compare this one to, if you could flip to the next slide, please, the sort of broader landscape, which it's a very busy slide. Don't worry about reading the logos. That's really not the point of the slide necessarily. It's more to show, you know, How is the vendor landscape changing to address some of these needs? And so part of what we do at Mercer is we track all these companies. And so we have our own research into all of them. We try to keep our pulse on what are the emerging technologies, what are the emerging solutions. You can see all the various advocacy and navigation services there in the middle. And so every year this sort of gets a little bit crazier and a little bit harder to read, but it's important to understand what solutions are emerging out there and can they be applied and provide value to Peb and to your members. And so with that said, I'll hand it over to Mitch to wrap with next steps, and then we will open it up to questions.
Yeah, so if we go one more slide, Rose. Thank you. So this is just a high-level timeline of our work over the next 6 months. So kind of starting in January, we've sent out the round 1 renewal letters. And so February will be the first board meeting. So we'll start to show the self-funded proposed projections, as well as the Kaiser fully insured initial rates, as well as administrative fees and things like that. And so, over the next 4 or 5, or not 4 or 5, 2 or 3 board meetings, 4 or 5 would be a little crazy. We'll start to introduce more of the renewals and some of the decisions and kind of get the board's approval. So that kind of wraps up our presentation for today.
Did you have a question, Sean?
Yes. So I have a couple of thoughts in response to that. Thanks for laying all that out. Good information. A couple of things came up for me as we were talking. One is the familiar discussion that I often bring up, which is the difference between cost and price. And oftentimes when we're focusing on renewals, we're talking about costs. But I am asking Mercer to have some focus on price, and here's what I mean. Cost is like a combination of price plus demand, right? Like the volume. And what is happening nationally, and probably is happening in Oregon, but I can't show this because I don't have this information, which is the point of my comment, is that because demand has gone down due to the pandemic, various medical systems provider networks are increasing their price in order to compensate, right? Because there's just less volume. And thus, when demand returns, whatever post-pandemic means, we're in for a really rude awakening, a bleak year because prices will have moved up and now demand has returned, and it's sort of like a double whammy. And we need to be able to see that happening. And when we are looking only at the cost, which is like demand is low, therefore our costs are low, therefore the renewals are like this, we're losing that. We don't have a lot of insight into what some of those local contracts are. And in fact, some of the prices for various procedures and such have gone up unbeknownst to us, but we discover it later when demand returns, and it's like, whoa, why is there suddenly an 8% increase this year? And it's because a lot of these contracts got renegotiated in the middle of the pandemic and we didn't see it. So you don't have to have an answer for that right this minute, but I just, as we're going into renewals, I want some insight into that we have our eyes on that, and that, if there's some negotiated change in price for core medical work, that those are temporary if that's necessary, that we're returning, when we return back to usual demand, that we haven't reset the floor higher. And just that we're on that. So just putting that out there.
Yeah.
Another thing related to this, but a separate concept is, and I know all of our carriers are interested in this as well, but I just want to be sure that we are all leaning into this, and that's preventive care and screenings. So it's, of course, screenings and preventive care went down during the pandemic. Of course it did. And therefore we will be reaping the consequences of those lost screenings and preventive care later. I mean, we already are. Acuity's going up, and the consequences of delayed care are starting to accumulate now. Cancers are being caught later. I mean, all the things. And screenings matter, right? There's a reason why we do them. There's a reason why they are cost effective and better for health. And they've gone down. So when over this next year in particular, over the contract year that we're negotiating now, this will be a critical thing to focus on to get those screenings back to where they should be. And I don't think that's going to just snap back into place without intervention. It's hard enough getting people to get screenings on normal years, much less now that it's almost like the past 2 years have trained people not to go to the doctors and do screenings, right? And so everything from just like teeth cleaning to colonoscopies, like we really need that to be working well, and we need all the carriers to be on their best game and have a plan for that's beyond the usual strategy, to be able to get our screenings and preventive care back up, to compensate for the loss of a couple of years, frankly. So there's that. And then finally, your discussion of behavioral health. We've talked about this before, but despite everything I just said, behavioral health is a different story. Behavioral health, maybe there does need to be an increase in price in order to have more access. Maybe that's part of the problem. And as we are expecting that behavioral health is going to increase on purpose because it was being underutilized before the pandemic, we have to plan on spending more in the area of behavioral health, and we have to compensate. And it's not like we get an extra layer of the 3.4% or whatever just for behavioral health, right? I mean, somehow we have to accommodate this new demand on purpose inside of our 3.4% while expecting that costs will go up, and that's part of the plan. And so that's tough, and how to navigate that and stay within budget is going to be not an easy challenge. But I just want to put that forward, that the cost containment things that I was just mentioning, and then there's behavioral health, where we actually are anticipating some increased costs, probably on purpose, because we are trying to increase demand and access. So anyway, those are my comments, and none of those three things are easy, but I feel like they are important for this next round of negotiation in particular. And I just want to be sure we had a special focus on them.
Yeah, those are all great comments. I would, on your first comment around sort of the unit costs, one thing that we can do, and I don't know when the last time this was done for Peb, is just to do a discount analysis for your self-insured carriers, at least. The one comment I'll make about that is that it's based on historical data. So, it might be something that we slot into a future year to see how that had changed during the pandemic and then how it changed post-pandemic. But I think there are also some cost pieces related to the transparency performance guarantees. And so that's something that we can certainly take a look at and make sure we're tracking how that sort of per unit cost has changed as sort of the revenue has changed for these providers. Regarding the preventive screenings, I think that's a very timely comment. And so talking about strategies for how we identify those members and then maybe do targeted outreach to them. You know, if you haven't had your teeth cleaned in 12 months, you show up on a list provided to us, and you get a postcard every 6 months or so, you know. So thinking about how do we outreach to those folks to make sure that they're going in and getting those screenings is definitely something worth talking about. And then I think you're dead right on the behavioral health costs. You know, increasing the reimbursement rates might be just what's needed to get more providers to participate in the network. You know, fortunately, you know, as your behavioral health care costs go up, it will hopefully reduce some of your costs in other areas because there's so much comorbidity with healthcare and ability to manage chronic conditions, for example, that you know there's this interplay between behavioral health utilization going up and other conditions actually potentially being better managed. And so that can sort of help offset any cost to, you know, keep that 3.4% in mind. But yeah, those are all great comments, Sean.
Spot on, for sure. Thank you, gentlemen, so much. And we are going to go ahead and we're running a little behind, but this is great dialogue, so we'll figure it out at the end. So next up is the standard annual update, and I've got David here. I think he just popped on screen. Good morning.
Hello.
And I'm going to let you give us your update. Thank you for joining us.
You're very welcome. Thank you for having us. David Scarce, National Account Consultant with the Standard. I'm joined by Beth Rourke, who is a Disability and Productivity Consultant with the Standard as well, to give a very brief annual update. I know we're behind on time. I will do my best to keep us on track here as best I can. We last met in, I guess it was January of 2020. So it's been a couple of years, even though this is called our annual plan update. But to just give you a little bit of insight about what we've seen over the last few years and maybe some impacts that COVID might be put in there as well. Next slide, Rose. And so today, just the impact of COVID, some disability trend analysis for short-term disability, long-term disability, the life experience we've seen for life claims, as well as our workplace possibilities program, and then some kind of key takeaways. Next slide, please. And one more. And one more, Rose. Nope, no, jumped too far. One more back, please. I'm sorry. The COVID slide didn't show up there. There. So are we missing a slide in the middle there? There should be one slide after. There we go. That's what we're looking for. Thank you. So real briefly, with COVID, we actually didn't see a lot of impact in 2020. Most of the impact we've seen with COVID has occurred in 2021, especially in the life insurance side. You can see here that little footnote there that 76% of our life insurance claims from COVID were incurred in 2021. From a claims perspective, just a little over 3%, just under 4%, I should say, of claims, life insurance claims between 2020 and 2021 were related to COVID, but 9.7% of the benefits paid out were related to COVID. So a little bigger jump than we would have expected on the life claims side. The 3.7%. That's we're in that 2 to 3% range as a company overall, that what we're experiencing from COVID, but Peb seemed to see a little higher incidence of that. Also got to keep in mind that we do have retirees on the plan, and about half of those impacted were retirees. On the short-term disability side, about 3% of the claims were COVID related, with just under 2% of that from a benefits perspective. were from COVID. The average duration of a COVID disability claim was 43.4 days. From I guess jumping back just from overall dollar perspective on the life insurance side, we had about $1.7 million that we paid out in life insurance benefits related to COVID. And on the disability side, about $422,000 when it came to the disability claims related to COVID. Next slide. And then one more. Great. All right, talking specifically about short-term disability, this little dashboard here, you can see from an incidence perspective when we're comparing the state of Oregon to kind of the national block of business, incidents are a little bit higher. Keep in mind, though, that this doesn't take into account plan design, so benefit waiting periods and benefit percentages and things like that also can impact incidents. So I don't worry about that too much. It's not significant. I think the things to point out here are the fact that you can see this decline between 2019, 2020, and 2021 when it comes to the claims we've received. So we've been seeing overall about a 14% decrease in the amount of claims that we've been receiving. However, from a dollars perspective, we've seen about a 10% reduction overall from the amount of money we've been paying out in the past. But you can see in 2021 that figure started to climb just slightly. And again, kind of goes in hand with what I was saying earlier, is that we're seeing a greater impact in 2021 than we were seeing in 2020 because of COVID. And the other thing just to point out on this particular slide is the top diagnostic categories, and Mercer alluded to this, mental health. You can see for the state of Oregon, and that green bar there is higher than the benchmarks of either standards block of business or the national block of business. Next slide, please. And then specifically to the results that we've seen, this is a kind of a 5-year snapshot here when we're looking from 2017 to 2021. You can see that for the most part, the state, which is the green bar there, kind of falls mostly within benchmarks with the exception of mental health. And that's where we're just seeing, and historically, the state of Oregon has always had higher mental health activity than others. Not specifically sure why that is occurring, but that's just kind of been a historic thing with the state. And if you jump to the next slide, you can see that from a mental health perspective, this is a little busy, but if you look at that mental health perspective, we're looking at 2019, 2020, and 2021, which is the blue, green, and purple bars there. Under mental health, you can see it's been increasing. So I think that kind of goes along with what we've been experiencing kind of with the anxiety around COVID. We're seeing more mental health claims, while a lot of our other claims, such as musculoskeletal, for example, which are typically the highest claims that we have, we're actually seeing reductions in those areas. And then one more slide. And this last slide in short-term disability is actually with regard to dollars paid. And once again, you can kind of see that the mental health, we've continued to see increases in payments through mental health claims, while we've seen decreases in payments through the musculoskeletal claims. Next slide, please. And then one more. Long-term disability, this is again another little dashboard here. Again, Oregon's incidence significantly higher than national block of business. However, this doesn't take into account plan design, and Oregon having the 90-day benefit waiting periods as well as 180 days, you tend to see more claim activity with those shorter benefit waiting periods. Just like short-term disability, we've seen decreases in claim activity between 2019 and 2021, although the numbers for 2021 on long-term disability aren't complete yet because you've got folks that might still be in a benefit waiting period that haven't filed a claim for 2021 yet. So I would expect those 2021 claim numbers to come up to closer to what we saw in 2020, but still a reduction overall from what we saw in 2019. And obviously the dollars paid for 2021 are significantly lower because we haven't realized all those claims yet. But another thing to point out is when you look at the top diagnostic categories, mental health just jumps up there significantly higher than benchmarks. Next slide, please. And this, again, you can really see how mental health is just significantly higher when it comes to claim activity than other diagnostic categories when it comes to benchmarking. And in fact, everything else is, again, right at or maybe can be slightly below benchmarking, but the mental health is just one that's really something that continues to be an ongoing historical issue with the state. One more slide, please. And then this, again, shows the activity over the kind of a 3-year span. Interestingly enough, on the long-term disability side, we've actually seen a reduction in mental health claims, but you can see they're still significantly higher in benchmarks, but they were really high. They were accounting for about 25% of the claims that we were seeing on the long-term disability side back in 2019. And now, down into the 18% range. So a nice reduction, I guess you could say there. But still, mental health is something that we continue to focus on, and certainly work with that in our Workplace Possibilities program that Beth's going to talk about in just a moment here. Next slide, please. There we go. On the life insurance side, the thing that kind of really stands out to me is that cancer claims are by and large the highest claim activity that the state has, and in fact is 20% higher than circulatory claims, which is typically your heart disease type claims, which is usually what you see in groups as the highest level of for cause of death. But in Oregon, it's cancer. And I don't know from, I'm assuming on the medical side, you're probably seeing that, in the medical plans, but we're certainly seeing it in claim activity on the life insurance side for the state. Next slide. And then this just shows you kind of the activity that we've seen over the last 5 years. And I think the interesting thing to point out here is that from a claim perspective, we've actually seen a slight increase in claim activity over the last couple of years, but we've seen a reduction overall in benefits paid. So while we're seeing more claim activity, the dollar amounts haven't been as high as they've been in years past. You can see in 2019, we were paying out over $11.5 million in claims, and in 2021, it was down to 9.4 million. So while we've seen an increase in claim activity, the actual liability associated with that has been less. And in fact, if you take the COVID out of it, it would be significantly less because, COVID was about $1.7 million of that amount between 2020 and 2021. So certainly, some good things there, although we do have seen some increased claim activity. Any questions on this before I turn this over to Beth to talk about our Workplace Possibilities program? Great. Hearing none. Rose, if you want to jump a couple slides forward, please.
Thanks. Hi, everyone. This is Beth Rourke. I'm going to give a very brief overview of Workplace Possibilities. Thank you. I'll have you jump forward one slide, please. So Workplace Possibilities is our program. We partner with you and your employees to assist them to provide return to work assistance when someone files a disability claim. Our main goal is to reach out to those members proactively when they do file claims to provide that assistance as soon as possible. We reach out and we provide many different benefits to your employees. It can be medical case management. It can also be behavioral health case management. We have a dedicated behavioral health team that supports return to work. So I think this is a great benefit to highlight here and potentially talk about how we can increase utilization in this program too. Our case managers also want to provide your employees access to other benefit programs. So we're more than happy to refer employees to existing benefit programs, EAP programs, any other health and wellness programs. So it'll be important as you bring new benefits on that we know about them so we can actually talk to your members about how to utilize these benefits and make those referrals. One of the other critical things we do is provide stay-at-work services. We identify employees who are struggling in the workplace with a disability, and we provide service to them to prevent a disability claim from happening. So we can get in, provide assistance when your HR teams refer these employees who are struggling. We can get involved and provide either case management, equipment accommodations, ergonomic services. This benefit is provided at no cost to you. It is a benefit built into the long-term disability plan. So we can provide professional case management services, ergonomic equipment, ergonomic services. So we can fund that all under the benefit in the long-term disability plan. I'm going to have you jump to the next slide here. This is really going to be just a snapshot of what we've done over the last 5 years. Over 2,200 employees have been referred for services, return to work services, and almost 200 stay at work, those claim prevention cases completed. Our return to work has additional benefit in providing benefit savings where we can get employees back to work sooner and save those days, save those absence days, and provide those benefit reduction days. If we look a little bit more in detail on the next slide, we get a snapshot of over 5 years broken down how many employees we have reached out to and provide services in return to work, as well as our success rate in providing those services. If we go to the next slide, we'll also break those down by diagnosis, which is right in line of what David was talking with claims. We see a lot of activity in musculoskeletal conditions and also those mental health conditions. So those are really important things we do want to highlight, those specific mental health and substance abuse claims where we can have specific designated services provided to employees. We'll go to the next slide, please. And really, this is the benefit here, the reduction in disability, those saved days, those saved dollars and days in disability where we have the reduction. When we are reaching out to employees, we're providing that those successful return to works lower than those industry benchmarks. We're bringing back employees to sooner than expected, and we're providing support to them to make sure they're safely returning to work and having the services they need when they get back to work. So this provides a snapshot over 5 years of the successful reduction in disability costs. And we'll go to the next slide. And then cost versus benefit savings. So we are spending money in order to save you money and estimated savings, benefit savings also. So this is just a slide showing our outreach costs, things we might spend on ergonomic or accommodations, and then your estimated benefit savings over the years, which is a great benefit to see. And let's go to our next slide. This is a summary of our net benefit savings, and we'll break that down on the return to work slide. On the return to work side, where we are proactively identifying and reaching out to employees. And also our stay at work claims, where we can really intervene and provide services before a claim is filed. So stay at work, we're going to talk about preventing costs, preventing long-term disability costs, and then those return to work costs where we're actually reducing the duration of disability. If we go to the next slide, we'll see a specific breakdown for the stay at work. When we take your claim costs, when we look at the number of cases we worked on, almost 200 claims, we assume about 75% of those may become a disability claim. Breaking down those numbers and what the average benefit payment for your employee is, we're looking at a net benefit savings of almost $800,000, which is really remarkable. One of the other things I've included in this deck, if we move forward a couple slides, is a couple of, and one more, our case studies. So I've highlighted a couple real life examples of employees we've helped, Peb employees. We worked with a licensed practical nurse who had some vocal cord issues, some paralysis, who could not project her voice in the workplace, which really impaired her communication in the workplace. So we provided voice amplification to that nurse so she could speak and communicate in the workplace. One of the next case studies on the next slide is also one of our musculoskeletal case studies where we worked with an employee who had back pain, who was really suffering sitting at a desk in one position all day. So we provided specialized ergonomic assessments, and we provided a sit-stand desk as well as an ergonomic keyboard and mouse and a specific adjustable height monitor. So we allowed the employee to get up and have movement during their day, provided specialized services and teachings to the employee about how best to use the equipment. And so that was all funded at no cost to you. So that provides a little bit of a highlight of kind of what we do and how we do it. And we'll go ahead and move forward here.
Yeah, and I'd just like to point out on the Workplace Possibilities program, this program is available to any member who's enrolled in short-term disability or long-term disability. So because the disability plans are voluntary, it's not something that applies to every PEB member, but only to those that are actually enrolled in the disability plans. But these are additional benefits, though, that we are able to provide to folks that are enrolled in those programs. All right, I'm going to bring this home now. Just last slide here, a few key takeaways. We've seen some reduction in incidence and benefit payments over the last few years on the short-term disability side, and COVID's only had a less than 2% impact when it comes to the short-term disability claims. We've seen a reduction in musculoskeletal claims in short-term disability when compared to 2019. Both short-term disability and long-term disability mental health claims are still higher than benchmarks. Although we've seen some reductions in the LTD claims over the last 3 years, noticeably, we've seen some reductions in those mental health claims on the long-term disability side, which is a good sign to see. We've seen a 10% increase in life claim activity over the last 3 years, but a 24% reduction in the liability associated with that, which was interesting. And we did have that noticeable impact from COVID-19 when it came to the life insurance claims of nearly 10% of the liability was related to COVID-19. Cancer is a significantly higher diagnostic category than the rest of those death reasons. And then lastly, we've seen some very good success, excellent success in our Workplace Possibilities program through that Return to Work and Stay at Work program. And that comes to the end of our presentation. Are there any questions?
David and Beth, thank you so very much. And I think all the board members know how to reach out to you if they have questions that come up. Sean, you just popped on screen. Did you have a question?
No, thank you.
Okay. Thank you. We do appreciate you so much giving us this update, and apologize that it's a 2-year update, not a 1-year.
No.
We will work on getting better at that, right? We think we have COVID figured out, maybe.
Hey, the last time we gave this update, we actually did it in person, so that's how long ago it was.
Believe me, I miss those days. So thank you very much.
Hey, thank you for having us.
Thank you.
Thank you. So we are going to put a real fast 10-minute break in. I'm going to honor the bio break. We're going to 10 minutes. At 11:22, we will start with Dr. Bachman and Kaiser Permanente. And everybody stretch, hydrate, do whatever you need to do, 10 minutes. And might have to do a little adjusting to the agenda, because this is good stuff, and there's not enough hours in the day. So 10 minutes. All right, it looks like we're recording and we're back. And I believe Dr. Bachman is also back. And the team, look at you guys, you're all popping up, all those smiley Kaiser faces. Good morning and welcome. And we appreciate that you guys are adjustable with the agenda. So if we want to go ahead and get started, that would be wonderful. Thank you.
We've never heard that term smiley Kaiser faces before, but we try to remain with equanimity in face of difficult circumstances, but smiling always helps. We're going to start with Jennifer Stacy, who is the Director for Strategic Accounts on our dental program, to kind of kick this off, and then I'll say some words, and Sapira will say some words, and I'll set my timer again for 20 minutes, and we'll go from there.
All right. Thank you, Dr. Bachman, and thank you all for having us today. So as we talk about our current work and our future efforts, we thought it'd be important to ground ourselves as to where we are now and how we've gotten here. And a lot of conversation has gone on about the past 22 months, and I think everyone knows that it has really significantly impacted our states and our nation's clinical structures. It's strained our public health organizations, as you're well aware, and it's pushed many of the support systems to the brink. And Sean discussed a little about a couple of areas of this, but COVID-19 has and will continue to drive costs into the healthcare system. That includes the obvious things like providing care for COVID, the vaccinations, but also the safety needs and the complete stress on staffing. So everyone's talking about the Great Resignation. Well, that's definitely begun, and it is impacting healthcare workers significantly hard. So, while we're not likely to understand what that total impact will be for a while, one area that we know is a real early indicator is the fact that the contracted workers that many of the health systems have traditionally used to help flex with demand has really skyrocketed as far as the rates have gone, because the demand is so high and the nurses are so difficult to find. And now as we see COVID running through, and you're seeing it in teachers and any sort of frontline staff, certainly in healthcare workers, as people have to be out as they get COVID, that really puts additional strains. Also mentioned were those other inputs. Sean and Andrew both talked about it, the patients that are coming in with higher acuity health issues and the dramatic increase for behavioral health and substance use disorder treatment. And then in the theme of, all COVID all the time, this past 2 weeks, we've got a new challenge with implementing the over-the-counter testing requirements. And that too will be another round of reimbursement that the health care system and Peb will absorb as we provide over-the-counter testing for our members and community. At the same time, we've seen the societal reckoning that really demands that we improve equity, diversity, and inclusion to support those who are most vulnerable. And, when we're talking about all the doom and gloom, that aside, we know that Kaiser Permanente is well positioned to meet all of these challenges. And we, like Peb and the OHA, are focused on the right work. So to deliver that quality care, to maintain affordability in the face of these rising costs, and to focus on service and equity. So today we'll talk about for 2022, we're really doubling down on the work to connect our members to care with a really strong focus on primary care, behavioral health, and chronic condition management. We'll also continue our efforts not only to build a diverse workforce, but to improve the diversity of healthcare providers in the future, which we know is a national problem. Finally, we'll continue to address those social drivers of health. So as Sean noted, this is incredibly important. We'll continue not only to screen members and connect them to social support through the Thrive Local Unitas platform, but we're also evolving care for our chronic condition management to be social care management, because we know that addressing those key issues outside of the exam room is absolutely key to addressing members' overall health. So now I'll turn it over to Dr. Bachman and Sapari to really go into detail about some of these specific programs and efforts that we're doing so that we can make sure that we keep that really eye on the ball, so to speak, to deliver your members quality care. Thank you.
Okay, on the next slide, you can kind of see our 6 areas of focus that we are excited about in terms of both opportunities for innovation, as well as places where we can really let value-based care shine, show to you the benefits of a fully integrated, capitated medical care environment, and how we have certain levers that a less integrated environment might have. So things that we're excited about and we're going to focus today on will be primary care and its importance, behavioral health, which has come up several times today and continues to be important. Things we can do in both inpatient care and outpatient care by improving the number of days our members stay at home and then reducing waste and variation, just standard business practice to provide both better quality and better care. Pharmacy management, which we've presented to the Peb board many times in the past, really one of our bright spots, our ability to really keep pharmacy costs as flat as possible and well under national trends. Sapari will talk about streamlining some of our more business-related efforts, including streamlining administration and some of the plan enhancements that members can look forward to in 2022. On to 2 slides in advance to talk about primary care. So we've always been a primary care-based organization, but we will continue to be that way. And in fact, we are expanding and focusing on it even more, recognizing that primary care gives us the key and the lever to provide value-based care that's based on relationships between clinicians and teams and individual patients. We think it's a key for customer service. We think it's a key for managing complex care with face-to-face teams based in primary care. It offers social care linkage. Members are most comfortable talking about their individual social needs in an environment that they're already comfortable in. It provides more opportunities for culturally responsive care, since primary care tends to be more community-based and community-sensitive. And then again, we are integrating behavioral health into primary care at a high level using what we call behavioral health consultants, which are trained, credentialed master's level clinicians that have expertise in common mental health problems, as well as mental health prevention, as well as substance use issues. So all of these things can go together, and we believe that invigorating and focusing on primary care for members that want to be paneled in primary care environments is really a key strategy to provide the best and value-based care. Moving on. So behavioral health, lots of work going on there. We've seen, we kind of acknowledged the high numbers of more than 1 in 3 Oregonians recognizing they have an anxiety and or depression issue, recognizing that many of those needs have not been met. Looking back, the need for behavioral health care has increased, and so has the demand. Looking at Pebb utilization for the past 3 years, we've seen 20% increase in outpatient mental health services delivered to Pebb member for each year consecutively for the last 3 years, and similar increase in addiction medicine services. Our plans for 2022 are to improve access by hiring staff, focusing many in primary care environments, though some in specialty mental health environments as well. We're going to improve our appointing systems by really streamlining it and aiming for one-touch resolution for mental health appointment. We're working on digital therapeutics. We're expanding digital tools for the pediatric adolescent population and continuing to train all of our staff and via self-service to tools online such as Calm and My Strength and other appropriate tools that can be used to enhance cognitive behavioral therapy in counseling relationships. We believe peer support is important. That's being used in addiction medicine services and is expanding to other environments in behavioral health as well. And finally, just increasing staffing. That includes increased case management for members with the highest level of behavioral health needs. We released and collated for the Innovation Work Group a list of our behavioral health programs, and we got to 32, and there were still several that we missed. These range from everywhere from programs to help pregnant people with addiction issues, to teenage eating disorder issues, to supporting families with behavioral health care needs, to really all over the map, to our outpatient residential program based in Clackamas. That's our alternative that can be used in many situations to avoid the need for more expensive inpatient utilization for addiction medicine and mental health. Again, we have the advantage knowing our members, being able to connect the parts, connect people to whatever program is best likely to meet their needs. Moving on 2 slides forward to our inpatient and outpatient care. And we really think about these as how do we keep our members at home more nights? If we can avoid unnecessary inpatient stays and inpatient days, we are improving safety, improving costs, and usually, almost always, improving member experience. KP at Home is our inpatient services based at our members' homes. We currently have 8 members with COVID in this program this week, and we have other members with other conditions. This is a very comprehensive service. Members have 24 hours access by video linkage to both nurses and physicians. That we can run IV, we can run high flow oxygen, we can really do almost anything that we can do in the hospital at a member's home. We can provide home health aides if necessary, and we provide the Wi-Fi if the member doesn't have adequate technology to do that. These programs nationally have been shown to be about 20% less expensive than inpatient care with really great outcomes, extremely low risk of needing to remove somebody back to the emergency room or to an intensive care unit environment. Not everybody's appropriate for it, but when they're appropriate for it, it can be a very useful program. A second thing we're doing on the right-hand side quality is is trying to keep people from avoiding inappropriate or unnecessary overnight stays. Currently, more than 80% of joint replacements are done in the hospital outpatient setting. We're moving to other surgeries there, such as thyroid surgeries, hysterectomies, spine surgeries. Each one of those, as we evaluate it, we have shown a high success of this program. It does take some foresight, some planning, some education, some availability of home care nursing and physical therapy services to pull this off. But when successful, we find our members are delighted to spend the night at home. We find that surgical outcomes are actually better with lower risks of complications and decreased number of days in the hospital. Remember, as we roll these programs out, we're able to use less of our beds in the hospital. We're able to bring more members in from other places in Oregon who are really even more strained than we are related to staffing issues in COVID. On to the next slide, please. These are a couple different pilots that we're doing and programs that we're doing. To the UPenn pilot relates to navigation, relates to assessment of social needs for our highest risk members. And we have formally evaluated a program at 2 of our clinics. And we did find that when we use this pilot to engage members at the highest level of social needs, we were able to reduce costs, we were able to reduce hospital stays, and we were able to connect members with social needs with community resources. And we're also improving our transitions and care. Obviously, anybody who's recently been in the hospital is at high risk for readmission, and lowering that always adds value. On the next slide, these are some strategies on waste reduction, reducing low-value imaging through a program we call Imaging Wisely. It's really just a check on the most efficient way to provide imaging, recognizing some MRIs and other expensive imaging are not adding great value when we think about it. And again, by having our different specialists communicate with primary care and our imaging specialists working closely with our surgical specialists, we can significantly reduce imaging. And then Wait, Don't Waste on the left side of the screen is a program really just reducing the number of surgical implements needed and having some organization in care so that a smaller number of tools to do surgery can be provided, and those can be more higher value. Anyway, millions of dollars of reduction in both of those demonstrated each year. And then the last 2 slides later talks about pharmacy. And just again, we are very successful in our pharmacy program through our organization of care, through our national pharmacy program, which is able to purchase at the lowest costs through our always great use of generic drug utilization because of a unified medical record used throughout the organization, through specialty medication management with high levels of collaboration between pharmacists and resource-intensive specialty care programs such as rheumatology, HIV care, and oncology. And again, you can, when just looking at the data, you can see that we've been able to manage our overall pharmacy utilization much better than national trends. With that, I will turn it to Sapari for the next slide related to streamlined administration and those cost containment initiatives.
Great. Thank you, Dr. Bachman, and hello, everyone. In addition to savings that we're trying to achieve through our care delivery services, we are also continually looking at streamlining our administration. So under the payment integrity programs, we have implemented various systems and audit functions to help ensure accurate claim charges from external vendors, such as the ED and all inpatient and outpatient services. We're projecting $6 to $7 million in savings for this upcoming year. We also have various internalizations planned for 2022, leveraging our internal resources and assets by bringing services in-house. A few examples of these include molecular genetic lab testing that we're bringing in-house, peritoneal dialysis, and opening up 2 new operating rooms at our Sunnybrook facility. And these efforts are targeted to save about $3 million in 2022. Next slide, Rose. Thank you. Under contracting, there's great advantage of being part of an organization that provides coverage to over 12.5 million members. We can leverage our national purchasing power to negotiate favorable rates and program-wide contracts. We are targeted to save about $13 million this upcoming year for these efforts. And as for discretionary spending, there's been a lot of downsides to the COVID-19 pandemic. However, there is an upside. The upside is that it has forced us to rethink how we do business. So although there is value, we know, in meeting and talking and learning in person, we've been able to cut down our spending by moving to this virtual environment. It's not perfect, as we all know. There's often times where I say, can you hear me? Can you hear me now? But we are learning. We are learning to flex, and we plan to sustain our savings in 2022. And lastly, just wanted to call out on our plan enhancements. Couple slides, Rose. Perfect, thank you. We wanted to call out a few of our new initiatives launched to support access and care to our members. Get Care Now is an on-demand video and phone visits with our clinicians. This is really our virtual urgent care option, and it provides 24-hour access to our Kaiser Permanente clinician through the computer, tablet, or smartphone. Chat with a clinician is offered to patients when they attempt an e-visit and their condition directs them to seek other options due to the nature of their symptoms. Chat enables our patients to ask questions about their symptoms and get the next steps for care. And this was soft launched late last year, and we have been averaging about 7,000 exams per month. Increased digital engagement. This was launched to support patients before, during, and after their appointments. So for example, we send appointment reminders 48 hours in advance of their appointment. As they're in our clinic, we remind them about any care gaps during their visit. And then after their appointment, we remind them to pick up their prescriptions. In outpatient pharmacy language translation, beginning late last year, our outpatient pharmacies can now offer prescription labels and drug information sheets in 14 additional languages, and that doesn't include English. So some examples include Arabic, Chinese, Korean, Romanian, Russian, Spanish, and Vietnamese. And lastly, but not least, our late sequelae clinic. We launched this new clinic to support members in experiencing prolonged symptoms of COVID-19. So according to the CDC, about 10 to 30% of our COVID patients will experience prolonged symptoms, which can vary from person to person and can range in severity. Our medical team reviewed hundreds of COVID cases to identify patterns and symptoms. And based on their early learning, they developed a panel of orders to help our clinicians evaluate symptoms and provide treatments to our patients. And I also wanted to mention, Sean, to address your comments, because I know what I talked about here is related to kind of that virtual care and online digital engagement. So we are absolutely focusing on health equity. We're not moving away from what we call the lower fidelity channels, which includes the phone and email. We still use that to try to reach our members. There's also a lot of work on seamless communication channels. So if a member prefers phone, we meet them there. If they prefer text, which uses or doesn't have to use a more reliable internet, we also meet them there. We definitely have a ways to go, but it is a focus for our national digital team to enable tools that are flexible enough to not leave people behind. And hopefully, we can continue to come back and keep you posted as we progress through these programs. And with that, I know that's kind of short and sweet. I'll turn it over to Jennifer to help close us up.
Thank you, Sapari. So, really, these are just a few highlights of the many, many work streams we have going that are all focusing us in the same direction as we work together with Peb and the OHA and others to make sure that we're delivering that quality, affordable care. Any questions from anyone before we turn this back?
Thank you so very much. I don't see any hands up, so we're going to go ahead and keep on moving. It's so good to see you all. Thank you.
Thank you.
Thank you.
All right, next up we have Moda, and Erica will introduce who all she has to present.
Great. Thanks for having us today. We're going to be talking about some of the plan enhancements that we're proposing for the next plan year. And as per usual, I have some guests with me today. So we're going to start off with Katie Sheeler, and she's going to be talking about some pharmacy enhancements. And then we'll move over to Dan Toma, who's going to talk about our new behavioral health program that we're proposing. And then Dr. Popowich will complete our presentation with a discussion on a prediabetes program that we're also proposing. So Katie, I will throw that over to you now.
Thank you. And Erica, can you hear me okay? If you can, everyone can.
I can. Yeah.
Yes.
Thanks, Katie.
Okay, great. Thank you. So I just want to go over a few programs. Rose, if you don't mind going to the next slide, please. I'm going to touch upon a few of the things that we have in store for 2022 and beyond. And then, as Erica said, off to Dan for behavioral health. So next slide, please, Rose. The first topic for pharmacy is the site of care phase 2 expansion. So as a quick reminder and background, we saw that claims data has significant variability in infusion drug costs at hospital outpatient infusion centers when you compare that to home infusion or doctor office infusions. And so beginning in 2017, Peb implemented our site of care program. And this program guides these medical infusion drugs, select list of drugs, to clinically appropriate and cost-effective sites of care. This is managed through the prior authorization process that's already established for these agents to assess medical necessity, and it helps steer the members towards a different sites of care for the select medications. Of course, this may not be clinically appropriate for everyone, and so exceptions are handled on a case-by-case basis when necessary. So we added a few more drugs to the list for 2021, and it's in place already for Peb, and these are the supportive oncology agents. These therapies
treat or prevent side effects that are associated with the therapeutic oncology medications or actual treatments for cancer. And again, this went into effect in 2021. We've though talked to the board about further expanding this program to scope and select therapeutic oncology medications. And this is something that you'll be seeing on the renewal. These particular therapies target and treat the cancer itself. Our approach is balancing the member and provider experience with the cost savings. And this will only apply to new starts to therapy. It'll only focus on single drug regimens so we can avoid the complexity and coordination of multi-drug therapies. It'll also make sure that we are avoiding agents that have pre-medication treatments or labs or need resuscitation equipment. So this is something, again, that you'll be seeing in our renewal. On the next slide, I'll touch upon the continuous glucose monitor and testing supply change. So this is another plan change that'll be proposed. As a quick background, the continuous glucose monitor continuously tracks glucose levels throughout the day. If a glucose level is out of range, an alert is sounded to draw the attention to the particular change, whether it's a sharp increase in the blood glucose level or a big decrease in level. This does not include insulin pumps, it's only a glucose monitor. And we do have medical necessity criteria for these agents to ensure that the right diabetic members are receiving this. So someone who has to test multiple times a day, has really high sugar levels or hypoglycemia levels. The testing supplies include things like lancets, testing strips, etc. So currently both of these buckets are covered under both the pharmacy benefit as well as the durable medical equipment benefit. And most people ascertain these supplies through the pharmacy benefit, but some people are still accessing through medical. So the recommendation is to only cover the CGMs and testing supplies under the pharmacy benefit only. This allows more visibility into what specific products that members are using. We can't identify that specific medication detail under the medical benefit, and we don't have the capability to ascertain that information. So we know that testing strips, most of them are safe and efficacious when compared to one another. And so rebates are often offered in the test strip space, and the nation really includes the rebate strategy for the lowest net cost of test strips. And again, rebates are 100% passed through to Peb. But not having insight into what's being billed under medical might leave some rebates on the table. And so this will make sure that billing under the pharmacy benefit, we're capturing all of the members who are utilizing the preferred product and are able to bill for those rebates and pass that through to Peb. There would be no change to the member benefit since members have a zero member cost share anyway. And let's see, we have done this for other groups, and we run a disruption report and make sure that we appropriately communicate 60 days or more in advance to the members. If there's a prior authorization set on the medical side, this would automatically be transferred to the pharmacy side. Automatically, it'll be manually transferred, but seamlessly to the member. So the last pharmacy endeavor before I pass it on is touching again on the emergency cellular and gene therapies. We've talked about this a bit in the past, but I wanted to note it here because the strategy continues to gain traction in 2022, and this really can help us stay below that 3.4% target. So quick overview on gene therapies. These are very costly and complex medications that are new to market. We're continuing to evaluate innovative approaches to mitigate costs of these therapies and ensure quality outcomes. Oops, Rose, if you don't mind going to the next slide. Thank you. One such space is the gene therapies, and these work to manipulate the expression of a gene or alter biological properties of living cells that treat or cure this rare disease. Pipeline is continuously growing. I feel like every notice I'm getting on new drug approvals happens to be in the orphan drug state or disease states that affect a very small percentage of the population. So we really wanted to set up a management strategy for if a Peb member
comes onto the plan or is diagnosed with a rare genetic disease, this will be already in place. One example is Jozinma. So this is provided by the healthcare side. I'm sorry, it's provider administered medication. It's used to treat a rare disease, spinal muscular atrophy. The pricing is about $2.1 million for the one-time infusion. And the clinical trial only evaluated 20 people because it's such a rare disease. So because of that, we want to ensure that for diseases like this and others, that we establish a center of care, center of excellence models, steering recipients of these therapies to the hospital with the expertise to manage these complex therapies. Many of these hospitals actually participated in the clinical trials for gene therapies. As you can imagine, with such a rare disease, not every hospital has the ability or knowledge to use the treatments. And so this really helped guide members to the hospitals that have the most experience and best outcomes. And as we talked earlier, these arrangements have overall costs in mind as well. So certainly want to make sure members are getting the best therapy, but at what price to Peb, that's definitely part of the conversation to ensure that the costs are compatible. So I just wanted to mention that, but on pharmacy, that's all that I had. In the interest of time, I went a little fast, my apologies. Are there any questions for me? If not, I'll hand it over to Dan Toma to discuss the behavioral health space. Thank you.
Thanks, Katie. So as a mental health clinician, I am just really excited to hear all the discussion about the importance of behavioral health now and the importance of making investments in behavioral health. And I want to talk with you about what we're proposing to do in the coming year for Peb. So to start out with, moving from paying for activity to paying for value in behavioral health has been a very difficult code to crack. But we're at a moment where I think we can really make some profound changes in both the way we finance and we deliver care. And so we want to propose to you what we're calling a coordinated care model for behavioral health, which is going to have some similarities to the coordinated care model for medical care. There's three real main themes that I want to touch on here: access, outcomes, and moving from fragmentation towards a cohesive system. So access, as you know, has gone from bad to worse. It's just so common for either members or Moda staff, when we're assisting members, to have to make multiple calls to providers in order to find a single provider who's got availability to see a new patient. Another aspect of access is finding the right provider who's got the right specialty. There are so many subspecialties within behavioral health, and really getting that right provider is a key piece of having a good treatment outcome. So what we want to do is we want to create a new and different experience for members where they have access to a behavioral health champion through Moda who can help them find the right provider, and provider who actually has availability on the first try, so you're not making multiple phone calls. And that behavioral health champion is going to be empowered with a decision support tool to help identify the exact type of need that member is experiencing and get them to the most appropriate provider on the first try. As we want to be able to provide scheduling on the spot, and or in other instances, just know ahead of time before we provide the provider's name to the member that provider has confirmed availability to see that member. Some things that are going to help us, one of the things that's going to help us with that is the virtual point solutions. So there's been a lot of talk about the virtual providers but the benefits as well as the challenges that go with them. Some of the benefits, one is that they can have specific clinical focus that gets a member to the really precise treatment that's going to be most helpful for them. They've got, they're able to tap into scheduling, making use of the demographics of their provider panel. So we're able to match people based on race and ethnicity and clinical specialty as well. And also will improve access based on geography, as has been mentioned previously. Second theme is outcomes, and one of the bad piece of news regarding our current state is recent study found that only 14% of behavioral health providers were using outcomes measures in their treatment. So this is the equivalent of as a primary care doctor not measuring your patient's blood pressure if you're treating them for hypertension. And there's all kinds of research that shows that systematically using an outcomes measurement improves the quality of treatment, decreases treatment failures, makes treatment happen more quickly. And yet it's not widely adopted, despite the fact that this has been a best practice for years. So the virtual point solutions are going to be helpful in that respect. If you think in terms of like Meru, and we're able to get really good outcomes reporting from them, there's a bunch of other solutions out there that are that are similarly tracking and able to report on outcomes and using that best practice. We want to invest in infrastructure to make outcome-based care much more accessible to our provider panel as a whole, and then use that to move into value-based contracts with our providers and really start to pay for outcomes and total cost of care versus just paying for activities. Last thing, theme, cohesiveness. So we've got 7,000 providers on our panel, and yet it's difficult often to find an appointment. We've got all these point solutions. So we want to provide an experience, again, where the member has a decision support tool, is able to identify the best fit provider for them. And then the behavioral health champion is able to make sure that that treatment is working for that member. So one of the most common scenarios in behavioral health treatment is that the member goes once, they don't feel like it's a good fit, and they drop out and they fall through the cracks. So we want to be able to ensure that follow up with the members and make sure that that provider was a good fit, and then using those outcomes measurement tools, make sure that members are actually getting the clinical benefit that they need from that treatment. And if not, then we're able to step in and provide appropriate follow-up to get things back on track. So it's a really quick overview of the direction that we're going. I look forward to talking about this in a lot more detail with you at an opportune time. I'm going to hand it on to Dr. Popowich to talk about prediabetes.
Okay, thank you, Dan. And in the interest of time, I'll try to make this as brief as possible. I know we're running behind, but I do want to talk to you today about a diabetes prevention program that we are looking to develop in-house here at Moda. But before I go into the program, I'll just talk a little bit about the problem, in that nationally, about 1 in 3 adults, over 88 million people, are pre-diabetic, with most of them not realizing they are at risk. In fact, over 84% have no idea that they are even carrying that diagnosis. Obviously, those people are at much higher risks for the complications of type 2 diabetes, heart disease, stroke, just to name a few. We feel that by adhering to a CDC guided diabetes prevention lifestyle change program, the risk of a member progressing to type 2 diabetes is cut in half, actually higher than half, greater than 58%. And for those over 60, that number is 71%. And a program like this would also reduce the serious conditions associated with prediabetes. Historically, engagement and retention in prediabetes programs has been low, and rates are even lower for Hispanics and other underserved ethnic groups. The core component for a program like this are weight loss, which is documented via diet and lifestyle modifications, introducing physical activity into a member's life, support groups, stress management, lifestyle coaching, and ways to adhere to the program. Next slide, please. Next slide. There we go. Thank you. So we are calling this our Pre-D program, our diabetes prevention program. And what we found was that there are third-party vendors out there who make a good effort in servicing this population. And they've been somewhat successful in engaging members, but where they really seem to fall apart is retaining those members to see them through the lifestyle changes they will need to make over the long term. We know that identifying members with prediabetes early and engaging those members effectively with incentives that we'll be discussing as the program comes into firmer light can lead to significantly better health outcomes. Certain social determinants of health can lead to a higher chance of developing diabetes. Therefore, enhanced targeted efforts at these populations will be an essential part of the program. So we propose our Pre-D program, an internally built diabetes prevention initiative to address these members' needs by incentivizing members to complete pre-diabetes screening through our new member portal and Moda 360, implementing CDC prediabetes defined programs of weight loss, lifestyle modifications, lifestyle coaching, one-on-one sessions with a lifestyle coach periodically, frequently throughout the course of the year to assist with individual goal setting, accountability, and program retention. And then lastly, providing incentive through the plan design to encourage engagement with the program and coordination with PCP 360. It's very brief, but that's the program that we are proposing, and I'm happy to answer any questions that you may have.
This is Sean, quick follow-up on the diabetes prevention program. Are you or will you be offering that program to OEB members as well?
Yes, we are.
You already are, or you will be?
No, this is we are proposing it for October 1 for OEB.
Okay. Oh,
yes.
okay. Thank you.
Thank you. Any other questions? Doesn't look like it. Thank you all so very much. All right, next up is Providence. And I've got Cash down as our presenter. Good morning, or I think, yes, oh, nope, good afternoon.
Yes.
Okay. Can you hear me okay?
Yes.
Okay, great. Hi, and yes, good afternoon. And I know we're really running behind and probably got a lot to get through here, so I'll try to move very quickly. I'm Cash Spencer. I'm the Senior Manager at Providence Health Plan, and with me today to present, I have our Chief Medical Officer, Dr. Bob Gluckman. So starting off, since in the essence of time, I will go ahead and briefly walk through what we're planning to do here. So we've broken our presentation into two parts. So we'll talk about our priorities for 2022, which are aligned with PEB's goals. So we'll start off with member support and navigation and what we're doing in that space, behavioral health, musculoskeletal conditions, and then diabetes management. Interwoven in our work and is cost containment, and then also cost management and health equity and inclusivity. So we'll make sure we'll point those out as we get there. And then finally, we're going to round out our presentation with what we're doing to further support comprehensive primary care, and then finally, what we're considering and exploring for 2023. I do want to just quickly, before we go forward, acknowledge the comments about health equity and solutions, because a lot of what we're doing right now is technology driven. And the requiring the use of digital point solutions we know won't work for everyone, has been pointed out, but we can expect that for the members who can use it, especially with accessibility being a challenge just across the board. If we can find ways to drive members to that and encourage those who do have the ability and the resources to use technology, then maybe we can open up some of those spots for people in traditional care that might need more of a hands-on support. But we'll be sure to touch on that as we continue to walk through. So next slide. So just starting off with our member support and navigational enhancements, again, technology being a driver, and we have leveraged technology to support members. So as a reminder, we did bring behavioral health in-house in 2021, and Bob will touch on that here in just a little bit. And as we did make that in-sourcing of behavioral health, we moved to a single front door model, which means that people call one phone number for their medical claims, behavioral health claims, pharmacy, etc. We have 24/7 access to crisis-informed, crisis-trained support services, and then also we added secure chat and email for member services through our My Providence account. So quickly, in what we've done new. So we've launched 24/7 voice-enabled IVR access to some of the common services that people call us for. So that could be understanding their benefits. It could be help with referrals, PAs, accumulator information, knowing where they are in their deductible and out-of-pocket costs. They can also order ID cards, even though you see there on the screen, we have mobile ID cards available. You can also order a new ID card through the IVR system. And then our support services have rolled out a new platform as well that allows for modular training to get information out to our support team quickly, and that includes information on benefit changes. We're using the platform for training for, say, DEI and health equity, cultural competency training. As new caregivers are brought, our employees are called caregivers, and new caregivers are brought on board. Those caregivers are also being trained on health equity and also other cultural competency things as part of the new hire training protocols, and that all happens through that training platform. And then finally, collecting of the Real D, SOD, SDOH, and then SOGI information in order to direct members to the providers and the resources that are most appropriate and meaningful for them in their health journey. And we talked about this several months ago about how we'd made some enhancements in our provider directory to include some of those cultural and community demographics and the search filters. This also allows our customer support teams to direct members to those resources as well. And just as a note down at the bottom, we did develop all of these programs in the spirit of leveraging some Peb member advisory groups. You'll remember several years ago, we had conducted a number of member advisory groups, and so it was through working with our member advisory groups that we were able to develop the content we're using in our member support protocols. Next slide. Sorry, I feel like I'm talking super fast. So we're going to switch into, really quickly, Dr. Gluckman, I just wanted to say we're going to switch over into mental health, and Dr. Gluckman's going to talk about that. But I do want to recognize as we move into our point solutions, so mental health, MSK, and diabetes solutions, Dr. Gluckman's done an amazing job under his leadership of ensuring that these programs are integrated into our care delivery models. So as a health plan, but then also working to ensure that we measure and validate the efficacy of these programs with the experts on our delivery system. So I just wanted to acknowledge that because I know that cost and then quality is also partially concerned. So with that, Dr. Gluckman.
Yeah, thanks very much, and really appreciate the opportunity to present to Peb this morning or this afternoon. As Cash mentioned, we've insourced behavioral health and brought all these programs in-house with an eye towards augmenting our staff and a strategic partnership with Beacon Health Solutions, but all of the policies, procedures, utilization management decisions, care coordination is all run through Providence and accountable. We're accountable for outcomes and cost containment. So things that have been added this year, crisis support and navigation, all internal. You can see a variety of services that are there. Navigation, one call, patients can get navigated to appropriate providers who meet their needs, so that's very individualized. Immediate assistance and triage for patients who really have higher acuity needs, and ensuring that people get timely care. Next slide. Wanted to concentrate a little bit on our behavioral health concierge service, which is an integrated telehealth model. But it's not just a telehealth model. It's what we call a blended care model. So it not only uses the services of a therapist, but it uses a digital cognitive behavioral therapy platform to help members develop self-sustaining strategies that they can take on into the future, so that they are able to build and develop skills to be able to manage their mental health conditions. The features of this program and this blended care model is that it offers expedited access to care. It's available for Peb members in Oregon, Washington, Idaho, Montana, California, and Texas. We have implemented a value-based care model for this program. It's an episode, case rate with performance guarantees. So we're focused when we present solutions to Peb is that we want to hold programs accountable to meet the outcomes that we know you care about. So in this model, we have performance guarantees around access, where 80% of the care is of the patient should be having an appointment within 7 days. We have a performance guarantee around member satisfaction with a net promoter score of 50, which is much, much higher than community standard. And we have a performance guarantee in the first year around outcomes measurement, and we will be implementing a performance guarantee on actual outcomes. In the first year, we wanted to get some sense of the baseline. And then the other unique feature is when Providence uses an external program, we want to integrate this into not only our health plan's ability to navigate, but also to community providers. So in this program, we have, if a patient needs a prescriber, we have a path to escalate that quickly and get them connected to the right source for prescribing, whether that be a patient's primary care provider or whether that be a mental health professional, a psychiatrist who can prescribe. If patients need their acuity level, and I will share, we have found that the Peb members have somewhat higher acuity than standard, that they get escalated to a regular source of care more quickly, because this program is really designed for people who have lower acuity conditions, that we can get people in fast, get them on a good path, and get them to complete their care with a therapist, so that there's capacity for new members to be able to be seen. Because as you know, there's a shortage of mental health providers. So it's also important that we use those providers wisely and efficiently. Next slide, please. We're gonna show you the first year experience for Peb, and then on the right side is the experience around the general book of business. What I will share with you is I think this service is underutilized, and there is a capacity to use this service for more members. We've served about 200 members to date. The average number of visits per patient is 5.7. The average number of visits in our other book of business, and I will share with you the utilization of another, not your size, but significant size, self-insured employer, is 5 to 10 times greater per thousand. So I think that, really working with the local departments and making them aware of this service is something that we could really do to enhance it. But I also want to kind of emphasize that average visit per patient at 5.7 is still about half of what it would be in a usual care model. So it really emphasizes the point of the benefits of a blended care model to drive efficiency, drives lower cost, drives better access, and gets more reproducible results. So these are things that I think we can build on in 2022. Next slide. Building on this concept of how we are able to leverage technology more to help members is an enhancement that we will have in mid-year is our Learn to Live program, which is a digital application combined with health coaching designed to have specific programs for social anxiety, depression, anxiety, insomnia, and substance use. It's a self-guided CBT program that can be used with a therapist but it can also be used independently. And we'll be focusing on making sure that our primary care providers are aware and use this program for members. It would obviously provide the opportunity for 24/7 access. Patients can be using the program in times and places that work for them. It's comprehensive. It really, again, emphasizes skill building. There are programs available to address concerns around COVID. It's available currently in English and Spanish. Family, friends, peer-to-peer communities are available to encourage increased social support. And there's a web-based ongoing care. And then the members who engage in the platform have an opportunity to use master's levels clinical coaches in a variety of communication channels. The other thing I would mention to you is that the cost for this program to Peb is no additional cost. It's free for members, and there's no additional administrative expense to Peb for our administering this program for you. Next slide, please. To give you some sense of the outcomes that are reported in the Learn to Live program, approximately 30% of members have improvement in their clinical assessment results, 44% improvement in psychometric outcomes when working with a coach, 94% of members would recommend this program to others, and the engagement versus traditional solutions is six-fold higher. So we're really proud of what we've done in behavioral health, and we're really looking forward to how we can enhance the programs that are available to Peb in the coming year. Next slide. We're going to move a little bit to musculoskeletal approaches. We've implemented Kaya Health as a digital-first musculoskeletal therapy program. It uses a computer vision technology to be able to give real-time information to patients as to whether they're doing their exercises correctly without requiring the presence of a physical therapist at that time. So excellent opportunity for people to be able to do things again on their own time. When we look at vendors, we're really looking for ways that we can do things in an asynchronous fashion that don't always involve a clinician in real time, because that's how we improve access and lower cost. The beauty of this program is that the care can be delivered as a mobile app on the person's own device, an iPhone or an iPad. They don't need to have additional wearables or no extra equipment. The hybrid care model ensures that there are superior compliance rates. Because of the availability 24/7, people can fit this into their workday or around their workday whenever. They don't have to take off time. They don't have to balance this with their other family needs. They can do this on their own time. There's published clinical evidence, and the cost of care is reduced by about 80%. Next slide.
Can I just add one thing to the prior slide quickly, Dr. Gluckman? Sorry, I know we're running out of time. I just wanted to note that the technology provides accessibility support for visually impaired members, hearing impaired members, and there are also audio and visual cues for those with differences in language. So Kaya has really done a great job of considering differences in equitable needs, ensuring that this works for everyone. Sorry about that, Dr. Gluckman. I just wanted to make sure that the board knew that.
Appreciate it. No, we're a tag team. The product evolution is we started to build this out in 2020. We've implemented kind of phase 1 in 2021. The innovations coming forward, this coming year is physical therapy oversight, physical therapist oversight, and an escalation path for the non-responders. And also within the Providence system, when patients are referred for physical therapy, they're actually looking for when members might be appropriate for Kaya upfront, which again would significantly reduce the cost for Peb. But in addition, it preserves access for other members who have higher acuity needs. There's a continued focus on this motion analysis advancement and the integration with, like I said, existing care partners. And then some advancements on member engagement using gamified content to keep people engaged and focused. Next slide. I want to present to you your actual one-year outcomes with this program. 512 signups, there's 276 active users. There's a 27% reduction in pain score and a 43% increase in quality of sleep. As that compares to book of business, a little bit better, both in terms of pain reduction and better sleep. And here's a testimonial of one of the Peb members on the benefits of Kaya. Next slide. We've also implemented and focused already on moving patients out of the hospital for musculoskeletal conditions. This slide represents the success of what we've done on total knee replacement. So the blue bars are the number of Peb cases in particular sites prior to our site of service medical necessity assessment. What you can see is the height of the blue bars in the inpatient hospital on the left, and you can see how much those have dramatically declined. What's even more important here is that I think is important for the Peb board to understand is that the patients that are remaining in the hospital have a higher rate of severity of illness, significant comorbidities, which warrants them being in the hospital. So if I just do a rough look at the proportion of patients with severity classifications 1 and 2 using ETG analysis, before it was about 50%, and now with a much smaller pool, it is uncommon. It's not more than 25%. So as you're thinking about looking at programs with bundles and et cetera, it's important to recognize that the patients that are now being done in the hospital are not the same patients that were being done in the hospital before. Those are high acuity patients who are at risk. You can see what we've done is a dramatic shift. The height of the orange bars is the patients move from inpatient hospital to outpatient. And we've had some increase in the ambulatory surgery center area, but could actually look to do more in this area. So one of the things for Peb board to think about in terms of 2023 benefits is to have a differential benefit for an ASC versus an outpatient hospital. And there could be some consideration for mileage if we want to preserve access in rural environments to allow care to be delivered locally. But I think these are things for us to discuss in the future. The main points is you can see the success of the program already, and the fact that lower acuity patients are really essentially being moved out of the hospital setting already. Next slide. To talk a little bit now about diabetes management. Providence Health Plan operates a diabetes prevention program that is already CDC recognized. That program includes, individualized goal setting and specific programs with a health coach focused on developing healthy habits. And so we already have full recognition from the Center for Disease Control and Prevention. Uses telephone, email, group visits, webinar, web video, etc. The innovation for 2022 is the next slide, which is really focused on patients who have higher acuity diabetes, multiple medications, and poor control. One of the things that we really wanted to focus on when we thought about using a third party is to recognize, first of all, I think we should actually be proud of the quality of the care that's delivered in Oregon. Oregon is a high quality state. And the idea here is to focus on the patients who need more than can be delivered in a primary care setting, but not just trying to work around primary care or marginalize the medical home model that we've built successfully. The emphasis on the VERTA program is to reverse type 2 diabetes. It's a non-surgical medical treatment program that emphasizes individualized nutrition therapy combined with a physician-led team. The difference between this program and many others is that the physician-led clinical team takes active deprescribing as a core component of the program so that the savings will be generated for those Peb members. So as patients lose weight and get better control, there's a clinician that's actually looking to de-escalate the meds that the patients are on so that you can get good control with less pharmaceutical cost. In fact, 94% of the patients who are served by Virta have medication reduction in the program. So we've identified the 400 top Peb members who have the highest risk and the highest cost, and we'll be pushing out the opportunity to engage in this program at no cost. Again, I would mention we are not adding any administrative cost from the health plan perspective to implement this program. And once again, when we implement these programs and vendors make promises, we want to hold them accountable. So there are performance guarantees. 100% of the Virta fees are at risk for reduction in hemoglobin A1C, reduction in weight loss, and they must achieve a 40% reduction in the pharmacy cost for these members. So again, cost reduction is pretty much guaranteed for Peb for this program, or you'll pay nothing. Next slide. I think I'm going to skip it in the interest of time because I know we're running late. You can refer to it, but it just gives you some emphasis of their success. Lastly, I think we want to talk about our programs to support primary care. As many of you know, Providence Health Plan, it was the only carrier in the state to participate in both CPCI and CPC Plus, the Medicare program to support primary care transformation. That program has now expired, but we don't want to see the gains that have been made and the programs that have been implemented in primary care erode. So we have developed a bridge program, but again, that program has some increases in accountability on these primary care providers to earn the case management fees that we continue to use to support them. The largest Peb assigned medical groups are all included. We are emphasizing their uptake of the technology features that we have. Some of them are pharmacy related. So our electronic prior auth, our real-time benefits program. There are programs and technology to help with care coordination. And then through our strategic accounts management team, we are there to provide support, but to have a greater understanding of a medical group's behavioral health integration opportunities and their continuation of their patient and family advisory councils that were required by CPC Plus, so we don't lose the gains that were made. Next slide. Just to give you some specifics around the features of the program, we'll continue to have quarterly reviews with medical group reports that look at our PCP profiles that emphasize the individual members who have gaps in quality and provide utilization information. On the pharmacy side, we have a couple of tools that they're incented to participate in. The real-time benefit tool is a tool that gives primary care providers the up-to-date information as to what is the lowest cost, most efficacious treatment for a member. And then the electronic prior auth tool that we have can help with reduce the PA burden and workflow. They're incented to use the pre-managed tool for discharge notification that helps with transitions to care and follow-up after emergency room visits. And then the behavioral health component of this is for them to continue to share with us how they're continuing to use those behavioral health providers that they've integrated into their program under CPC Plus. And then we can use that to also coordinate with the programs that the plan operates to optimize outcomes. Next slide, please.
Hey, Bob. I'm wondering if we could maybe hit the high points on these. Just I know that they're close to end on the meeting, and I want to be sensitive to that.
Sure.
Okay.
All right. So there are other features around the patient experience and expectations on what they will do to ensure that care is timely and engaging their provider, their patient and family advisory councils. And then there are requirements for them to engage with us so that we can continue to hear from them and learn from them about how we can help support them better. And then I think there's one more slide that is yours, Cash.
Yep. And just kind of rounding it out, and I certainly don't need to read through all of these. These are just some of the things that we have on our docket for consideration as we go into 2023. We have included in the appendix section for the board information on the Smart RX Assist program. We did present this back in October, but there is a slide back there in the appendix for you to reference what that program is. There is savings associated with that program. Also, Moda had alluded to a program for gene therapy. We too have a gene therapy program with our Providence Cancer Institute, and so there's information on that. So if the board is interested in rolling out those types of programs, we can do it equitably on the Providence side as well. And then also in the appendix section is information on all of the point solution information that we talked about here today, so that the board can further review those sites to learn more about those programs and how they can support PEB members. With that, thank you so much. I know we went way over, but thank you so much.
No, Cash, thank you. And I appreciate, you all having to speed up, and we're constantly trying to manage our agendas, and there's so much good. We never want to stop the questions, and we never want to stop the open dialogue. Does anybody have any questions for Providence? And do not look at the clock. If you have a question, please ask your question. Well, thank you. And thank you, Dr. Gluckman. And we did move. We did side emails at the break, and we were able to move Innovation Work Group since we've run into 12:33 now. And Jenny, thank you. We appreciate you. I asked Rose, and she said I had no public comment, but I'm going to make sure one last time to see if we had any public comment.
I don't have any, Kim.
Thank you. Ali, did you have anything that you need to bring up? I know you're on vacation and you're joining us.
Yeah, no, I just wanted to thank the carriers for the presentations, and I know it's a lot of information, but next month we'll look at many of these recommendations in the context of the 2023 renewal decisions, and really how these solutions can address some of the issues that have really been exacerbated by the pandemic. And so we'll have a second chance at this, and I know it's a lot of really good information, so thank you.
And welcome, Dawn. It's usually not quite so rapid pace, but sometimes we just have a lot of material to cover, and that's what happens. Does anybody else have anything for the good of the order? Hello, Greg. Good to see you. Okay, having heard no additional comments or anything for the good of the order, I'm going to go ahead and call adjourned our first meeting of 2022. And our meeting is adjourned. And again, thank you all so much for being here and listening in and participating and taking so much care in your presentations. We appreciate all of you. Thank you. Goodbye. Have a good vacation, those of you that called in on